So good evening, all the faculties and delegates. On the behalf of Corona Remedies Private Limited, I welcome all the faculties and delegates for the Searchlight webinar series. That is the 03 third series, which is initiated by the Cancer Prevention and Relief Society and supported by the Corona Remedies. The topic of this webinar is the obstetric hemorrhage, which is on this Searchlight 03 webinar series, which is associated with the Vijayawada, Kakinada, Iluru, Vizag, Rajahmundry, Guntur, and Bhimavaram societies. And today it's my immense pleasure to welcome our Program Director, Dr. Asha Jain. So, Dr. Asha Jain is a Medical Director of CPRS, and also she is associated with the SMSA Hospital, Raipur, and elected member of Chhattisgarh Medical Council. Dr. Asha Jain is also associated with so many societies like IMH Chhattisgarh, FOXI, Food and Drug, Medico Surgical Equipment Committee, and ISCCP, and IMA Raipur. And earlier also she was in the with the various designations and associated with the societies like Raipur Obs and Gynae Society, IMA Raipur, and also Rotary Club of the Raipur. And Dr. Asha Jain has got so many certificates and awards as a recognized as the recognition. And she is an interest in various fields like saving the uterus, fetal medicine,
Okay.
ultrasound.
Let's go forward.
Okay, thank you, ma'am. Please take it forward this webinar.
I welcome everyone to this third episode of Searchlight, and the light this time is on obstetric hemorrhage. At the very outside, we will pray to the divine and then proceed with the scientific session. May we have the stuti, please?
वक्रतुंड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देवा सर्वकार्येषु सर्वदा
With prayers to the divine and prayer for light in this Navratri Parv, I welcome Vijayawada, Kakinada, Iluru, Vishakhapatnam, Rajahmundry, Guntur, and Bhimavaram societies. I welcome our chief guest, Dr. Pankaj Desai sir, our guests of honor, Dr. Archana Verma ma'am, and Dr. Leela Digumarti, and also our speakers, Dr. Padmaja and Dr. Annapoorna, chairpersons, Dr. Akkamamba and Dr. Nirmala Devi, Dr. Sitarama Raju, Dr. K. Chandrika, Dr. B. Venkateswara. Also, my co-moderator, Dr. Sujayasri Sangita, and panelists, Dr. Kavitha, Dr. Geeta Shri, Dr. Niharika, Dr. Uma Shankar, Dr. Padmaja, Dr. Padmavati, and Dr. Narasavani. Welcome all of you to this program. And now I hope the searchlight is effective and we are able to shed some light on a topic that affects all of us. So now maybe just proceed and have the CV of Pankaj Desai sir. So I welcome you, Dr. Pankaj Desai sir. He is a teacher of teachers, and actually he doesn't need any introduction, but it is my privilege, my honor to say a few words about him. He is a consultant obstetric gynae at Janani Maternity Hospital, Baroda. He is Dean of Students, Medical College, Baroda, Associate Professor and Unit Chief, Department of Gynae, SSG Hospital and Medical College, Baroda. He has 7 gold medals, has many international and national awards, starting from when he was a young student, Young Gynec Award by AOFOG, Most Outstanding Young Gynecologist 1987, Foxy Tamaskar National Award for Best Work in Infertility 93, International Fellowship Award, ICOG 2003, Best Publication Prize by Jogi 2005, Lifetime Achievement Award by Foxy 2022. He has many international and national recognitions. Visiting Professorial Fellow at Liverpool Hospital, Sydney, Australia, President Foxy 2007, President State Organization of SOGO 1988, President Baroda 1987 to 89, Chairman Foxy Committee on Medical Disorders in Pregnancy, and Convener Scientific Committee SOGO 1990 to 94. He has had 61 orations, 776 guest lectures, 107 research papers, best papers 9, books authored 13, contribution of chapter to different textbooks 45, and blogs written 27 and read by 94,702 people. So that is just great. And I'm also a member of your website, sir, and read it quite regularly. The updates come on time. So it's an honor to have you on this platform to bless us all. And I seek your words of wisdom.
Honorable Dr. Asha Jain, an associate for nearly 30 years now. Honorable co-chairman, if she is the guest of honor, Dr. Archana, Dr. Leela, Dr. Padmaja, Dr. Raju, and so many others. It is my good fortune that I have been able to personally come to your societies, all societies, because some of them like Iluru and Bhimavaram and all were part of other societies. So all societies I have visited. It is my good fortune. Vijayawada, I was there in September 2000, and Vizag, Padmaja has been kind to me. I have given 2 of your orations. One in November 2000, if you remember, NTR University of Health Sciences oration, and Dr. Achyut Menon oration in November 2009, guest lecture at your 38th CNE in 2004. It must have become now nearly 50 plus CNEs. One I could not come. I was stranded at Mumbai airport, and because the connection failed and I could not come. Guntur has also been very kind to me. I delivered their Guntur Medical College oration in November 2000, and the master class of APCOG in July 2019. So I have a relation of my heart with AP, and you have always been very kind to me. I don't like to just talk all nonsense as a chief guest. Chief guests, and Dr. Asha knows that chief guest addresses are usually also ran. I have changed it for last many years now, and it started from Ranchi. I tell a story, and today's story is about obstetric hemorrhage. They are true to life stories which I have collected over a period of time. Even this cap today is having a story, but I will not tell that for some other time. And this story is titled The Old Man, His Beedies, and His Daughter. The story goes like this. I remember as a resident doctor, when I was doing post-graduation in obstetrics and gynecology, there was this senior lady consultant in our department who always had her anger on the tip of her nose. We all used to be terrified of her, and many would run helter-skelter on seeing her. Once, while I was doing some post-operative routine work in my ward, obstetric ward, I heard a big commotion near the operation theatre. She was shouting at the top of her voice. Inquisitively, I went closer to find an old man standing in front of her, trembling, literally trembling, and with folded hands as if pleading for mercy. She was blasting him. It seems on coming out of the operation theatre, on finishing some difficult surgery, she saw something very unpleasant. There were beedi stubs. You know what is a beedi? A very cheap form of cigarette. Stubs littered all around, plump near the door of the operation theatre. I did not need more than a minute to understand what must have happened. The man must be smoking and had thrown the stubs around. And this lady must have seen the litter and flared up. She didn't leave till the old man, literally in tears, collected all the beedi stubs and threw them in the dustbin. Tidiness restored, all well. The lady left with a gleam of victory in her eyes. We had all nearly forgotten the episode. In the evening, after all teaching sessions were over and all had left, I went back to the post-operative ward to complete my remaining work. There I saw that old man sitting, or I should say rather squatting on the floor near a young woman who was obviously the patient, who was seemingly operated. He was holding her hand as the patient may move the hand and thus dislocate the needle of the running drip. Those were the days when we used to insert needles. I am sure Dr. Padmaja, Dr. Leela, Dr. Sitarama, Raju and Annapoorna know that we didn't have these vein flows at that time. So somebody had to hold the hand. If you move, it will call what we call as it would go trance. His face was completely stoic. He was looking out of the window, staring vacantly at the dark sky. Winter days, darkness used to fall early. I quickly pulled a stool for him so that he could sit a little more comfortable. He looked up at me as he sat on the stool and he just sighed. He spoke nothing. Have you had something to eat? I asked. He didn't reply. Wasn't the answer obvious? I sensed the fear that was doing round in him again. He had not eaten a single morsel, I was sure. Tea and biscuits were arranged, but he seemed to be too scared to take it. He was so clearly hungry. His silence spoke out loudly while he did not utter a single word. He was too afraid to eat in the hospital, more so from the morning episode probably. Having reassured that he did not worry, I arranged a peaceful corner for him outside the ward in some privacy and got on with my work. After about half an hour, or maybe around an hour, so deeply engrossed I was in my work, but I felt someone was staring at me. This is what we call as awareness. The five senses don't sense it.
Hello.
Awareness is beyond your five senses. I felt someone was staring at me and I looked up to find that old man. He was peering at me from the window. He looked up. As I looked up, he smiled gently and in the Indian tradition, folded his hands just to say thank you, said nothing and went back to the patient. I left him in his space. After a couple of days, I could see the man in the hospital compounds, now visibly relaxed, but still very silent, sitting in the corner for the gates to open and visiting hours to commence. I walked up to him and just placed my hand on his shoulder, making it as comforting as possible. I asked him, how is your patient? He replied, she is much better now, sir. A gleam came on his face, a father's face. I know what it is because I am a father of 2 daughters. I know. Who is she? I asked. She is my only child, sir. This brings tears to my eyes. She is my only child, sir, he said. Her uterus was torn. Obstetric hemorrhages. Her uterus was torn. She had a ruptured uterus. He did not know the word ruptured uterus. Her uterus was torn, he said. We were tossed from primary health center to referral hospital. And from there, here. She was operated here, sir, and is now saved. The entire picture was now so clear. This man's only daughter, only child probably, was on deathbed that day. She was getting operated. He was facing a real possibility that what would come out from the operation theater would be simply her dead body. Ask that what it means to a father. He must be in unimaginable, undescribable stress. In that stress, he must have smoked one bidi after the other. Little did this simple man realize that he was in the hospital and therefore not supposed to smoke or make the place dirty. Did it matter? Do such rules matter at such critical times? His had smoked away in sheer agony. At the prospect of losing his only child, we, the doctors, on emerging from the operation theater, did not care to tell him what the situation was now. Instead, we blasted him. After all, he had made the hospital dirty. How dare he? He had smoked in the hospital. I have never forgotten this incident in my life. I know that as doctors, when we operate on a patient, we are not operating on one human being, but on the entire family. The agony is the patient is anesthetized, so he or she doesn't feel the pain. But the family is not under anesthesia and is undergoing a mental surgery, all in consciousness and pain. Lest we forget. Thank you, Dr. Asha, for the honor. God bless you and God bless all your efforts. Thank you very much.
Thank you, sir. Thank you, sir. After that heart-wrenching story, don't feel like saying anything more, but the program has to go on. Let's hope it makes us more empathic towards the families, and we are always empathic to our patients, but for families, yes, we don't really think we are so much, in that aura of what we have done. So we to get down to the earth. Thanks for the reminder, sir. And Mehulji, may I have Archana ma'am's CV, please? So now it is my pleasure and honor to invite Archana Verma ma'am. She has been the Vice President of Oxy in 2021. Before I give her entire CV, what I would like to say is she is one person who's literally a phone call away. You message her, she's always ready to help. So thank you so much, Archana ma'am. She is the founder president of West UP ISOPAP chapter, past president Ghaziabad Gynec Society, organizing secretary North Zone Yuva Foxy 2016 and UP ISAR. She was the chairperson of Public Awareness Committee Foxy 2016 to 18, executive board member of NNF India, executive member Endocrinology Committee CEFOG, past medical officer, postpartum program, JNM Medical College, Aligarh. She is the India Book of Records Award winner, Dhira Award 2022, DC Datta Award for Best Foxy Focus, President Foxy Best Committee Appreciation Award, UP Governor RTI Department, Uttarakhand Governor Appreciation Award for Menstrual Hygiene, CRPF Director Appreciation Award, V for Stree Award, Women of Year Health Award from IS Wives Association, Champion of Foxy 2019, Wonder Foxian, Award for Work for Reproductive Health, for women. More than this, she will speak now. We will hear her blessing, and you will know her very well. Most of you must already be knowing her, but over to you, ma'am. We would love to hear a few words from you.
So, thank you, Asha, and thank you for inviting. It's always a pleasure to talk to Asha, especially. I always get connected with her whenever, and she was my friend, and later on become my almost like a family. She is such a caring person. I really like her, one of my favorite. And after Dr. Pankaj Desai, sir, he's a guru, and whatever he says is so impactful that we always remember, and it is good for future. See, obstetric hemorrhage is one of my favorite in work, because being a public awareness person, I always say I'm not a professor, I don't teach anything, I'm not an academician. I am simply awareness is my passion. And for hemorrhage, only one thing is such an important thing: minutes matters. And the patient's health, society health, and doctors. Very recently, you must have heard that because of so much of pressure, Dr. Archana Sharma committed suicide in Rajasthan. That was another heart-wrenching story. Dr. Pankaj Desai sir will, I think, notify it later in his stories also, because not only the mother are important, it is the doctors who are also important, and saving the mother is something important. वो अमिताभ बच्चन का dialogue everybody must have heard, मेरे तुम्हारे पास क्या है, मेरे पास माँ है. So when a PPH, all the patients, obstetric patients, are young patients, and when they lost life, the most important impact is on the baby. Imagine he has lost the word. So if that is a thing, husband ko bhi, they can get another wife, everybody can, doctor also can forget and everything, but we should be so concerned. And this is one of the preventable death. And being working in protocols, and teaching our staff, and knowing what is a code blue, how to tackle the emergency is something very important. And as Dr. Pankaj Desai sir said, yes, I got almost gold medal in MD, because I was a senior resident, and on duty the day there was some problem, so we were also called to do a duty. And when my case came, so it was APH case by chance, and I was wearing apron, and my all pockets were that the teacher, the examiner asked, what is in your pockets? Have you Sir, madam, I have taken lunch, but these are for the patients because I am on duty. And then she said, what is in this? Just show me. So I had a lot of rubber tubings and injection F-Colin and Syntocinon, Methadone. And so I was, in our days, the pockets were full of medicines. And then she said, what a wonderful person that she is. She is so concerned. There's not, she said, show me everything. So there was no toffee, and she was really very happy. And she said, if the doctors are like this, who is the teacher? Who is the like teacher? So in Aligarh Muslim University at that time, Professor Shaista Mohsin, we used to really admire her a lot, and she taught us. So PPH, today very well taken topic by Dr. Asha Jain, and Chief Guest Sir blessing will always be with the South India top societies. So I will say that the because you people don't understand Hindi, so I will say somewhere, sometimes the sun always rises. So it is the from where it comes, it is to be remembered. And thank you very much, and all good wishes to Asha and my Padmaja madam and Dr. Leela Digumarti. I'm sorry if I take the name wrongly, so I will not take. So Dr. Leela madam and Dr. Annapoorna and all the speakers and chairpersons and panelists and moderators and coordinator for this program, best wishes. Let's be together and let's keep meeting. And Pankaj sir, if Pankaj means Kamal, and now nowadays we all are praying that we should always get blessings of Pankaj sir, So thank you.
మ్యూట్ లో ఉందని తెలుసు మ్యూటే కదా.
Thank you,
sir.
ma'am.
Dr.
Thanks a
Pankaj,
lot.
Whenever we see you, listen to you, I always somehow, I don't know what about others, I always get my hemoglobin rise by 2%. 2% and my heart and hemorrhage and everything becomes normal blood pressure. So teacher should be like this and moderator should be like Asha Jain. Thank you, Asha.
Thank you, madam. Thanks a lot for those loving words. It's really a pleasure knowing you. And now I have Dr. Leela, who has kindly agreed to be a guest of honor at this program. She is a dear friend, a person who is really concerned with preventing cancer in women. She is an MD, DGO, DNB, FRCOG. She's a gynec oncologist at KIMS Icon Hospital, Visakhapatnam. She is the president of ISCCP, Indian Society of Colposcopy and Cervical Pathology. She is a certified colposcopy trainer by ISCCP. She's a member of many societies, DNB teacher and examiner for over a decade, organizing secretary ISCCP 2019 National Conference at Vizag. Since 2014, with several NGOs, she has been creating awareness on vaccination and screening for cervical cancer with regular camps in North Andhra. She is a master trainer in several colposcopy workshops across India, a very gentle, dear, and committed human being. Thank you, Dr. Leela, for being here and gracing the occasion. Thanks a lot. And I would love to have some words of blessings from you.
Yeah, good evening. Thank you very much, Dr. Asha Jain, for your kind words. And I know I'm not practicing obstetrics for the last 10 years, but before that, I was doing a lot of obstetrics in Hyderabad. So your topic, obstetric hemorrhage, I know it is one of the main causes of maternal mortality even today in India. Even though the maternal mortality has significantly dropped to two-digit figures, and actually, I think according to the latest figures, Andhra Pradesh has got 45 per 100,000 and Telangana has 47 per 1,000. That means we are almost reached the SDG goal of 3.1, preventing maternal mortality. So that is all the hard work of the obstetricians who are relentlessly working for mother and child care. So as all the seniors have said, doing obstetrics in the past when we were students versus doing obstetrics now, I think the younger generation has got lots of advantages. Basically, the ultrasound has revolutionized a lot of antenatal care because, you know, you diagnose placenta previas, you diagnose so many things, whichever is the cause for antepartum hemorrhage quite early. But what I have learned over the years with my experience in India, back home, as well as in working in Saudi Arabia and UK, as obstetricians, we all have to work with a lot of anticipation. Anticipation is very, very important. And sometimes we forget very basic things of checking the blood groups and maintaining an adequate hemoglobin for women, because these are all the very important factors. And likewise, if you're dealing with complicated cases like especially placenta previa, there are guidelines now that how much blood you need to keep ready when you are planning to deliver, and if you're planning to do cesarean, how to involve the seniors. You need to be prepared how it is going to be, whether you are able to deliver safe or whether it ends up in a hysterectomy, like Dr. Pankaj Desai was saying about the horrific experience of the mother having a torn uterus. So, and of late, we are having so many cesareans, the cesarean section rate also has gone up. So we all need to be trained to handle the sudden obstetric hemorrhages in the form of uterine ruptures, especially the scar dehiscence and other things. And of course, postpartum hemorrhage. So only thing what I have learned, and especially by looking at the guidelines and other things, anticipation, preparation, keeping everything ready. And I know with all these conferences, we do have fire drills. So we need to have a regular fire drills about managing obstetric hemorrhage. Everybody who works in the labor wards should be familiar with the protocols, guidelines of managing both antepartum and postpartum hemorrhages. We should not run when the things happen. We need to be ready with everything before we actually start delivering the mother. Postpartum hemorrhage sometimes happens so suddenly. I know we do and expect when we deal with big babies, my twins and women who had antepartum hemorrhage, placenta previa. We know all the reasons for postpartum hemorrhage, but in spite of that, suddenly it can happen. So, and many people think that postpartum hemorrhage doesn't happen at C-sections, but one should be very, very careful when after delivering the placenta, delivering the baby, they should never be in a hurry to deliver the placenta. So they should follow the same steps of what we follow at vaginal delivery. I think these are some of the things I have learned with my experience in obstetrics, and I had wonderful teachers in Visakhapatnam where I did my MD, and even at Hyderabad, the places where I worked, and also had the wonderful opportunity of train some of my students with whatever little knowledge I have gained. And I think that is what I can just share my experiences. And I know even though I'm not practicing obstetrics right now, I have not forgotten the obstetrics, that I can say. And I'm very happy to listen to the youngsters who are going to share their experiences. And I also wish Dr. Asha Jain all the best for two things. One is she's going to do the national conference of ISCCP in April 2024 at her place. So that is the one what I am basically concerned with. And she's also contesting for the Food, Drug and Medical Instruments Committee of FOXI as a chairperson. I wish her all the best, and I also wish all the best to the speakers here, and my regards to Dr. Pankaj Desai sir and Dr. Archana Verma. Thank you, and I'm hoping to have a wonderful webinar from all of you. Thank you, all the best.
Asha, can you please permit me to leave now?
Thank you, sir. Have your dinner. Have your dinner.
Thank you.
Thanks a lot for being here so long, sir.
God bless you. God bless
Thank
you.
you.
Thank you, sir. Thank you.
Thank you. Thank you,
And
Dr.
thank you,
Leela.
Leela madam also. Leela ma'am,
Once an
thank you. I
obstetrician,
want to
ever
meet
an
you.
obstetrician. So with this, we end our inaugural session. Thanks a lot, dignitaries, Dr. Pankaj sir, Archana ma'am, Leela ma'am, for being with us. Thank you, Corona, for facilitating this session. And with the permission of seniors, may I now proceed to the scientific session? May I have the CVs of the chairpersons, please? So, our first chairperson is Dr. Basa Akkamamba. She's an MBBS MD obstetric gynae, presently working as HOD and Professor of Gynae at Government Medical College Rajamundry. She is the President of Kakinada 21, 22 and 23. She has received the Foxy Achiever Award in 2023. She is a gold medalist and recognized as the best outgoing student of Rangaraya Medical College of 1983 batch. And her topic of interest is high-risk pregnancy. So, welcome, madam.
Thank you, madam.
Next. We also have Dr. Nirmala Devi Bachoti. She is a DGO from CMCH Vellore. She has many diplomas, FART, FMAS, DMAS. She is also an LLB. So, Shri Kanak Mahalakshmi Hospital, Eluru, Andhra Pradesh. She is the present president of Eluru Obstetric Gynec Society. She is the organizing chairperson of APCOG 2024. She has Vishisht Seva Puraskar Awardee 2007 by X-Ray Organization Vijayawada, Excellence Awardee 2007 by Healthcare International Hyderabad, Glory of India Award by FIIS New Delhi, Champion President's Awardee Rotary District 3020. For the Rotary year 2014-15, she is a major donor to Rotary International. She has donated US $10,000 to Rotary International, Assistant Governor 2018-19. She has served as District Chairman Maternal and Child Health and District Chair for NCD also. Her special interests are social service, music and singing. She sings classical as well as light music. So over to you, chairpersons, to introduce the speaker for the session, Dr. Padmaja. May we have Dr. Padmaja's CV, please? Over to you, chairpersons.
I'm Dr. Nirmala.
Dr. Akkamamba and Dr. Nirmala, ma'am.
I'm Dr. Nirmala. Very much happy to be the part of this session. And I'm very happy to introduce Dr. Padmaja. She is having affiliations of FOGC, IMA, FCGP, IMS, PCOS Society India, ISAR, AP, chapter of ISAR.
Madam, if I may interrupt, please don't need to read everything, madam. You can just introduce me simply and we will go ahead with the scientific session.
She had her works everybody knows. Awards she has the Dr. G.N. Mathur Prize in Physiology, Dr. Rama Memorial Gold Medal in OBGYN, Prize in Free Paper Presentations at 4th APCOG at Kurnool Medical College, and positions Chairperson Charter of ISAR AP, President Vijayawada OBGYN Society 2019-20, Secretary APCOG Society 2017, Organizing Co-Chairperson South Zone UFOGC 2018, Special Interests are Cell Biology, Reproductive Endocrinology. I'm very happy to introduce Dr. Padmaja to this session.
Thank you, madam, for the kind words.
Thank
and
you.
I thank Dr. Asha Jain for giving me this opportunity. Without much ado, I will be going ahead with the topic that I was asked to speak on abruptio placenta. As you all know, placental abruption is premature separation of all or part of the placenta after 20 weeks gestation from a normally situated placenta. So this is a major cause of antepartum hemorrhage, affects 1% of pregnancies worldwide, with the ranges in different ethnic population between 1 in 80 to 1 in 250 deliveries. And as we know, women are pushing the boundaries of reproductive life, and as fertility experts, we do have people coming more than 35 years and 40 years coming for childbearing, and that is one risk factor. And different ethnicities, especially the African American blacks, have one of the highest risks of abruption. And in all the factors that cause abruption, what are the alarming factors that whenever we see it, we should keep awareness of abruption in mind, like how we should be alert for PPH, we should be even alert for APH, and in them hypertensive disorders, all of them. Gestational hypertension, preeclampsia, chronic hypertension with superimposed preeclampsia, all of them have a higher incidence, and the PROM also. And when Dr. Pankaj Desai was talking about smoking, active smoking, passive smoking, they are a very big risk factor. And now with changing society, use of cocaine will also be associated. There is a familial history that in families with siblings having abruptio, there is an increased risk. So therefore, it is very important not to forget the principles of history taking, including the family history. And whenever women have fibroids, especially if the placental implantation is on the site of the fibroid and there is a big fibroid, there is an increased risk of abruption. And one of the biggest risk factors is prior abruption. And if we have an multiple pregnancy or chorioamnionitis, even that is associated with higher incidence of abruption. And one of the subtle markers is that we have an unexplained increased HCG or maternal serum alpha fetoprotein, or a decrease in papain and estriol. They are, when you look at the moms, they don't have a chromosomal or a genetic anomaly. But in these people, because these are the proteins that are associated with placentation, abnormal placentation is one of the risk factors. And we also know that people with lupus anticoagulant and thrombophilias have an increased incidence. One of the emerging risk factors is hyperhomocystinemia, which can occur because of folate B12, B6 deficiency, or due to mutations of MTHFR leading to inability to form methionine from homocysteine. So this is one of the risk factors. So when we look at the incidence, the complication, it depends upon which group we are looking at. In PIH, almost 14%. In chronic hypertension, 1.56%. And one of the increasing incidence is in cases of trauma. If you look at all trauma, 6%. If you look at major trauma, almost 1/4 of them are associated with placental abruption, and even placenta previa is associated with abruption. And there are a large number of motor vehicle accidents that are occurring, and there were studies in US where it was seen that 1.3 million people die with that. In the youngsters, it is high. And if a woman is, in spite of using a seat belt, if she is involved in a motor vehicle collision, she has a almost 50% higher chance of having injuries. So when we look at these particular, the amount of trauma that occurs, the risk of abruption depends upon where the seat belt is placed, what is the width of the seat belt, what is the collision speed, and what are we hitting against, what is limiting our force. So if we want to minimize the placental site abruption and trauma, as you can see in this graph, when the velocity is less than 10 kilometers per hour, this is the force that occurs if the seat belt is worn above the tummy. And the higher the speed, the more the force. So it is very important to tell women to wear a seat belt below and in the lap, so that the trauma on the placental site and the shearing force is not too high. And domestic violence is not rare. We have had lots of incidences of hearing about domestic violence, especially in pregnant women. During the time of COVID, we've heard a lot. And that's what Dr. Shanta was telling, that it is a global phenomena. And remember that we need to give women some privacy and talk to them to know if there is any other thing. And not all risk factors carry the same weightage. So as you can see, I've highlighted, when we look at the socio-demographic factors, it's the maternal age, smoking, use of cocaine that are on the top. Previous placental abruption, you can see it is 258, that means 258% higher. So if there is a history of abruption, don't take it light. If there is a uterine anomaly, if there is a thrombophilia, hyperhomocystinemia, chronic hypertension, pregnancy-induced hypertension, and any vaginal bleeding after 28 weeks, don't take it light. And of course, placenta previa. And what happens is there is hemorrhage in the decidua basalis, there's a formation of hematoma, the pressure leads to spread in the hematoma. If it is small, it is self-limiting. If it dissects a lot, it releases a lot of thromboplastin, the bleeding into the myometrial area, the intravasation of the blood, the progressive placental separation. This leads to a tonic uterine contraction. Uterus becomes woody hard. There is an increase in the intrauterine pressure. There is, because the placenta is being compressed from outside and inside, there is a compromise in the placental circulation, which leads to worsening of the hypoxia because the placenta as such is smaller right now. So the varieties are either concealed, revealed, or mixed. And the diagnosis is clinical. It is the clinician who should be very alert whenever a woman says any of the following signs: sudden, severe, continuous abdominal pain where the uterus feels hard and woody. If that bleeding can be very severe, or it can be just dark blackish. And one of the classic teaching is that the shock is out of proportion with the severity of the external bleeding, because we don't know how much clot is inside. And fetal hypoxia depends upon the site and of the abruption and how big it is. And when an ARM is done, usually the blood fluid, the amniotic fluid is uniformly red. When we do a CTG, we see frequent contractions, we can see fetal heart abnormalities. And whenever there is a severe abruption with consumption of the coagulating factors, we will have a coagulopathy. And all these changes, it will be systemic. All the body is affected. There will be fibrin clots in the hepatic sinusoids. There can be renal vasospasm because of the massive hemorrhage. So we need to be alert that just delivering and is not the end of it. We need to look at the other organs because there can be acute cortical necrosis, there can be shock proteinuria. And sometimes there is just pain and you see absolutely nothing. And in these instances, ultrasound is a very useful tool. Never ignore a woman who says she has pain, because we need to check the viability. Early abruption, the blood can be isoechoic or hyperechoic. It is only after 2 weeks after the acute phase that if it's a small clot, you see this yellow sign where when you press the transducer, you can see it wobbling around. And sensitivity is very less. You can see only 25%. That means almost 75% of it, the ultrasound, the radiologist might say it is absolutely normal. So please don't send the woman home when your clinical suspicion says that something is wrong, because negative findings do not exclude abruptio. And main role is we need to know the viability. We need to see how much amniotic fluid is there, and we need to rule out a placenta previa. And the clot can be subchorionic, retroplacental, preplacental. Retroplacental hematomas, because they cut off the blood supply, are bad for the fetal survival. And size of the hemorrhage is also predictive of the fetal survival. On an ultrasound, it might look very benign, but when you see the retroplacental clot, it is usually huge. We have to keep the differential diagnosis of placenta previa, vasa previa, heavy show, any local cause, uterine rupture, chorioamnionitis, preterm labor, and other sources of abdominal pain. Grading, you can use the Sher and Shatland, where mild is a retrospective diagnosis, moderate is fetal heart abnormalities are high, the classical signs are there, but the fetus is alive. Severe is when we've lost the fetus and the coagulopathy is severe. Or we can use the page classification, which is essentially similar. The management is whenever we suspect, we need to individualize timely care depending upon the severity, maternal hemodynamic, fetal status, gestational age, presence of labor, and the facilities that we have for our NICU care and looking after the woman. So immediately place a wide bore needle, admit her, draw blood, get the cross match, check the blood type again, because we should not be missing an Rh negative woman. She might, this abruption will lead to a severe sensitization. Do a CBSP, let the fibrinogen, look at the clotting factors, look at the renal function test. And if there is maternal shock, massive hemorrhage, cervix is closed, we might need to do an emergency cesarean. But if it's already a labor in progress, accelerate the vaginal delivery by amniotomy, adequate analgesics, and give a good uterotonic and keep a close hemodynamic monitoring. So the principles are: look at the vital signs, look at the fetal heart rate, send the baseline investigations, catheterize the woman. If negative, give an anti-D. If it is less than 34 weeks and it is a small clot, and they're stable, try to postpone the delivery till 36 weeks by giving antenatal steroid, monitoring the bleeding hemorrhage, and check for the fetal growth. And women should be in hospital till at least 48 hours of no bleeding. And even if we need to discharge her, keep an emergency person on call, keep the blood emergency. Maternal mortality with modern technologies and early diagnosis will be low, but fetal mortality, depending upon the degree of separation, underlying cause, and the gestational age, is very high. We need to keep in mind that large transfusion, large hemorrhage, multiple transfusions, DIC, presence of stillbirth, all these can increase the mortality even in the woman. And in women who survive, this can cause Sheehan syndrome. Hypovolemic shock can lead to renal damage, and covular uterus is a severe form where there's a concealed hemorrhage, massive intravasation of blood. Because it does not really interfere with the uterine contractions, it's only scary to look at. There is no need for hysterectomy. Dark port wine, patchy or diffuse color is there all over, starts at the corner, spreads to the other areas. It can extend into the broad ligament. There will be necrosis, uterine muscle infiltration, and it is between the middle and the outer layers that the blood is predominantly present, causing that look of covalent uterus. But subserosal rupture can also cause intraperitoneal bleed. And the different covalent uterus is not unique to abruption. It can also be there with placenta previa, amniotic fluid embolism, and preeclampsia. Looking at Sheehan's, one of the first warning signs is failed lactation, amenorrhea, breast atrophy. Later on, we'll be seeing hypothyroidism and adrenocortical insufficiency and loss of pubic axillary hair. Looking at the fetus, the most important prognostic factor is the prematurity. Growth restriction, low birth weight can be there, hyperbilirubinemia can be there, and 10 to 15% of survivors of placental abruption do have neurological sequelae. And even with chronic abruption, there is a little abruption, then it stops, stabilizes, the fetus looks good, but slowly, because a large part of the placenta, we are losing its function, there will be a oligohydramnios. So Cavo sequence can also cause preterm birth and chronic lung disease. As I said, risk of recurrence is very high. So at every point of time, if it is there, we should try to get the best obstetric outcome in that situation for that woman, for that baby. Because if you think next time we will be more careful, we might not get a next chance, because next time the risk of abruption after one abruption is 15%. And after two abruptions, 1/4 of them have. Risk is higher with severe abruption, risk is higher with fetal demise. So how can we do something to prevent it? Yes. Give folic acid, methylfolate in people whom we suspect having the MTHFR mutations or beta histine. Early detection, effective treatment of preeclampsia. We have the gestosis score, right? Every visit we can do that. Anytime more than 3, be on a high alert. And now almost all my staff there, you stick that in your labor room, stick that where your weight is being taken, where the BP is being taken. Automatically everyone will write and they will give you a high alert. And in polyhydramnios, if you are decompressing, use ultrasound guidance. Avoid forceful external cephalic version in breech, and avoid supine hypotension syndrome. Make sure that we tackle anemia in the antenatal period so women can withstand blood losses. And as I was saying, if you have a suspicion of abruption, do an examination, get the fetal state, grade the abruption, get the hemoglobin, get your blood, get your coagulation profile, give crystalloids, get ready for blood transfusion, look at the urine output, check the fetus. If it is revealed she is in labor, augment and deliver. Not in labor, ARM and vaginal delivery. Can't do it, do a section. If it is concealed, then expected management is only an exception, not a rule. To conclude, placenta previa and abruption are the major causes of antepartum hemorrhage, perinatal morbidity, mortality. Painful bleeding, abruption. Painless bleeding, usually placenta previa. Identify the risk factors and keep the patient under observation, planning delivery near term for stable patients. But if there is severe bleeding, do take active action, don't wait too long. And thank you, Dr. Asha. All of us are together in this journey. A woman should not face mortality, morbidity for what we consider a physiological process of childbirth. This is what only women face, and men don't go through it. So we should be there for our women. Thank you very much.
Thank you so much, Dr. Padmaja. That was, your slides were excellent.
Thank you.
Didn't even feel like, moving my eyelids. So maybe have the chairpersons to say something, please. Nirmala ma'am, you're muted, please. You're muted. Unmute yourself.
Yeah, Dr. Padmaja has given the elaborate description of risk factors and different weightages of all the risk factors, and the most importantly, accident and seatbelt wearing has been explained so well, and she has given the USG findings. Negative findings are not the diagnostic point of accidental hemorrhage. That's most important. This is a clinical diagnosis. and that should be kept in mind of every clinician, because sending the patient for scanning and then seeing that there is nothing in the scanning and we can be rest assured it is not like that. So I'm very thankful to Dr. Padmaja to hear to her and to the organizing committee for giving me this opportunity. Thank you very much.
Dr. Akkamamba, would you like to say something, please? Ma'am, are you there?
I think she's there. Her name is there.
Yeah, madam seems to be there actually. Madam's long in. Ma'am, would you like to contribute a few words, ma'am?
So I think we proceed now, and if she hears us, we can take her opinion later. We now proceed to the second lecture. Dr. Padmaja, that was really excellent. We can take the questions at the end. So the second lecture is going to be on the second part of APH, that is placenta previa spectrum. Our chairpersons are Dr. Sitarama Raju, Dr. K. Chandrika, and Dr. B. Venkateswara Rao. So I will be introducing the chairpersons. Dr. V. Sitarama Raju is an MD DGO FICOG at Sri Krishna Health Center, Vizag, Andhra Pradesh. He is currently the president of Vizag Society 2023. He has worked in Jipmer, Pondicherry as senior resident for 2 years, 86 and 87. He worked in government service at King George Hospital for 14 years. And since then, he is in private practice. He has presented many papers in state, national, and international conferences. He has attended a lot of workshops and CMEs. He was selected for WHO fellowship in 1998. He worked in US for 6 weeks and Canada for 6 weeks in IVF and laparoscopy. Welcome, Dr. Sitarama Raju, sir. We have Dr. Chandrika K. Ma'am. She's an ex-Major Indian Army Medical Corps, professor and senior consultant, obstetrician and gynecologist, simulation consultant, endoscopic surgeon, and robotic surgeon at GSL Medical College and General Hospital, GSL Swatantra Hospital, Rajamundry, Andhra Pradesh. Welcome, ma'am. Honored to have an army person between us. She's a member of FOXY and IAG, president of Rajamundry Obstetric Gynec Society 2023. She's trained in advanced laparoscopy, hysteroscopy, and robotic surgery. She has many awards and accomplishments. And her areas of interest are high-risk pregnancy, gynec endoscopy, laparoscopy, and robotic surgery. So she's taken part in the tsunami awareness and all. Next, please. We have Dr. B. Venkateswara Rao, who's the president of Guntur Society. He's presently working as professor and HOD, Katuri Medical College and Hospital, Guntur. Previously worked as professor and HOD, Guntur Medical College, and honorary president, Guntur Gynec Society, past president 2019 at APOX, Andhra Pradesh. Over to you, respected chairpersons, to take it further and introduce our speaker, Dr. Annapoorna Yalla. Dr. Raju, sir, please proceed.
Dr. Annapoorna Yalla, she did fellowship in gynecological endoscopy in MDR University, and the daughter of simulation board consultant at ES Medical College, Rajahmundry. She is a member of the endoscopy, SIG, and IFS South Zone, and she has past president of Rajahmundry and OBGY Society. She has published 30 publications and participated as faculty and speaker in many international national conferences. Thank you, madam.
Thank you, sir. Dr. Venkateswara, sir, would you like to introduce the topic a bit?
I'm going to tell, madam, about
Yes, sir.
placenta previa. All of you know about the incidence of placenta previa, 4 to 5%. Placenta previa can lead to complications such as vaginal bleeding, which can be life-threatening for both mother and baby. The main symptoms of placenta previa is painless vaginal bleeding during the second trimester of pregnancy. Diagnosis typically made to the ultrasound, other imaging studies. Management of placenta previa depends upon the severe of stage of pregnancy and many cases. If condition not severe, may recommend bed rest, close monitoring. If condition is severe, do cesarean section and deliver the baby safely, as vaginal delivery can be dangerous in these cases. I am very grateful to Asha Jain for giving me this opportunity. Now I request Annapoorna Madam to start the lecture.
If I can, I'll start sharing the screen. Yes.
Yeah, Dr. Annapoorna, you may share. And Dr. Rao, sir, would you like to say a few words?
Yeah, placenta previa, sometimes it becomes a challenge in the, sometimes the placenta previa or abruption, it may sometimes be very difficult. If both are there, it will be a challenge to the obstetrician in the management. Anyhow, we'll see Dr. Annapoorna. She'll be presenting. Wish you all the best, Annapoorna. Please proceed.
Thank you, sir, both of you. And thank you, Dr. Chandrika. Thank you, Dr. Asha Madam and Sujayasri for having me. Today I'm going to talk, Padmaja Madam, can you see my screen? Yes. Dr. Padmaja.
Please make it full screen, Dr. Annapoorna. Make it full screen.
Full screen on my window, ma'am. For you now? Is it full screen for you, madam?
No, it's not full screen yet.
How do I do it then? It is full screen on my window.
Double click on
now, sometimes when you're sharing, no, the two windows will be open. So share the window where you can't see the rows. Stop the share.
Just give me a minute. I should stop the share.
And share the one where this line of slides you can't see. So there will be multiple windows open, no?
No, madam, I have only one window opening. Anyways, I'll try once again.
Yeah, try once again.
No, I cannot get it.
That green button, screen share, if you move your mouse down, you can see that.
That I'm sharing, madam.
Now share again. Let's see.
I'll start sharing the entire screen.
Yes.
Yeah.
Double click to entire mode, it's written. You're sharing my picture. Oh, okay.
Now, okay?
Not yet. Okay.
Let's go on.
Yeah.
Can you see the whole screen now?
Otherwise, also you can go ahead, I think.
Okay. Right. Thank you for setting the screen and the stage for me, Padmaja Madam. Placenta previa, as sir told, it affects about 3 to 2% of all pregnancies. And with the concern of raised cesarean section, placenta previa and definitely placenta percreta is increasing a lot. As sir told, it is painless vaginal bleeding in the second or third trimester of pregnancy. It is a nightmare to most of us. As you know, classification, it could be complete.
Slides are not moving. Slides are not moving.
Again.
Well, in your laptop, it is also full screen. So first you remove that full screen from your laptop.
This is a desktop. How do I remove the full screen?
Escape.
Just escape.
I did that, and it is now. Now, what view are you seeing?
Now we are seeing your second slide.
Second slide.
Okay, second slide you can see.
Yeah. Click on.
Classification, it could be complete or partially covering the cervix. A low-lying placenta is where the edge is within 2 to 3.5 centimeter from the internal os.
Slides are still not moving, Dr. Annapoorna. Not moving. We are not at the classification. We can see it on the left side.
Oh, what do I do then? Okay. Now, can I go clicking like this?
Slide sharing, madam. Slideshow, you will start on your Microsoft PowerPoint, madam. There is a small TV-like thing you press.
Yes. Slideshow from current slide.
Yes.
Right? Now, is it okay?
No, it hasn't.
No.
from there.
Start from beginning.
Otherwise, put your mouse on your, now we've got the classification.
Yes. Okay, then I'll start. I'll go ahead like this if it is okay with you.
Yes.
Yeah.
Okay. Okay, so classification, everybody know that it could be low-lying or marginal placenta previa, and all this placenta previa, 90% of them will be classified as low-lying, and most of them migrate. Migration is not just that placenta will move, but because the upper uterine segment has a lot of blood supply, and relatively the lower uterine segment, the part of the placenta in the lower uterine segment gets atrophied. So it is an apparent migration. And not only that, the lower uterine segment keeps on increasing as the advanced gestation goes on. So the placenta will appear migrated. Now, are my slides moving now? Can I ask? Hello?
Yeah, it's moving, madam.
Yes. So if about 26 weeks, if it is covering os by more than 2 centimeters, the likelihood of resolution is really less or 0. If it is more than 2 centimeter, the likelihood of migration is 100%. And if it is less than 2 centimeter, about 89% will migrate. So if it is more than 2%, usually they move away. Now, this is the classification according to the pictorial classification. Etiology, all of us know, either it is a dropping down theory, persistent chorionic activity, big placental surface, defective deciduum. And the incidence, placenta previa and placenta percreta, if you see, it keeps on increasing with the number of cesarean sections. And if you compare both placenta previa and percreta, you can see that placenta percreta increases rather in an alarming rate. So placenta percreta, though today it's not my topic, I wanted to include it in this slide. Risk factors, maternal age, multiparity, cesarean scar pregnancy, hysteroscopic myomectomy, all these we are doing these days in a large numbers, especially in the infertility community. So it increases the risks of placenta previa, percreta, and even abruption as well. Now the diagnosis, most of the often diagnosis simple 2D ultrasound done in a good hand is enough. Doppler and MRI are required to differentiate between placenta previa, percreta. The specific ultrasound and Doppler pictures for placenta accreta are multiple vascular lacunae in second and third trimesters, loss of normal hypoechoic retroplacental zone, retroplacental myometrial thickness if it is less than 1 millimeter, or if on Doppler if there is a turbulent flow with color Doppler through lacunae and extension of villi into myometrium, we have to be alarmed and think it could be placenta accreta syndrome. Differential diagnosis, one should always remember it could be subchorionic hematoma, abruption, cervicitis, cervical cancer erosions, placenta, vasa previa, marginal sinus rupture, trauma, varicosity, and tumors as well. And approach extensive counseling should be done to the patient and their relatives. Informed consent should be taken whenever we are admitting, saying that the pregnancy could be needed to be terminated. So consent should be taken for preterm deliveries and even operative deliveries. It should be a multidisciplinary approach. We should involve the senior colleagues on this and involve the anesthesia, pediatrician, urologist if necessary. Specialized care and precautions should be taken to prevent other comorbidities like anemia, preeclampsia, and if they are present, to correct them optimally. Scheduled delivery should be done in a tertiary care center. Adequate blood and blood products should be typed and kept ready. At least 2 to 3 blood should be kept ready. Normal delivery can be contemplated in type 1 and type 2A.
Online meeting.
And surgical principles of any placenta previa case, skin incision. When it skin incision, a vertical incision is better because we will be able to view a larger surface and we will be able to do the other maneuvers as well. However, a transverse incision also can be done. Bladder mobilization, if the placenta percreta is not there, bladder mobilization should be done adequately. And because if we need to do any maneuvers or if we need to take the stitches in the lower segment, the bladder should be mobilized adequately. Uterine incision, if preferably it should be given above the edge of the placenta. If not, sometimes you can take through and through incision through the placental surface as well. Placental extraction should not be done. It should be left to separate on its own. However, if there are bits of placenta attached, you can try manual extraction or you can leave it and remove that part of the myometrium and suture it again. Repair should be done meticulously, hemostasis should be achieved, and closure should be done. And a drain always is important to be placed in these kinds of major surgeries. If unfortunately there is excessive bleeding, resuscitation with blood and blood products should be done, and standard surgical procedures should be attempted to control hemorrhage depending to our surgical toolkit what we have. Pressure on bleeding sites like distal pressure or packing. I always ask my sister whenever the edges are bleeding, just hold till we get an instrument with hand. Or packing with mop could be done. Intrarenal aortic compression with the fist of the hand can be done and can be left every 5 minutes till help comes or till we deal with an acute bleeder. If we have this Phyllis clamp, we can pick up the aorta and it can be cross clamped. Even for about 1 hour also we can cross clamp till we work on the uterus and we try to repair all the sutures. Tamponade can be done by various mechanisms. One can use a mercury balloon, one can use a Foley's balloon, one can use a condom balloon to give a tamponade. Massive transfusion protocols depending upon the institutional protocols. In our institute, whenever we tell massive blood transfusion protocols, we mobilize 3 units of blood, 3 units of FFPs and platelets. And they should be given in a ratio of 1:1:1. So if you give 1 PRBC, 1 FFP and 1 platelet should be given in addition to the blood. Planned cesarean hysterectomy, if percreta is suspected, always should be discussed with the patients and discussed amongst the colleagues, and a planned cesarean hysterectomy can be attempted. And whenever needed, when the uterus cannot be salvaged, emergency hysterectomy also can be resorted to. The triple P procedure, which is a famous procedure, which involves 3 main steps: perioperative localization of the upper placental edge on the table, pelvic devascularization. This can be done by the placing the infra-aortic bilateral balloons before the delivery, and once the baby is delivered, these balloons are inflated, and once we remove the placenta, the balloons always can be deflated. And placental non-separation with myometrial excision, followed by the repair of myometrial defect. These are the triple P procedure. It is little not practicable in our kind of setups because we won't have so much of resources and resource personnel always, especially in kinds of emergencies. This is a picture wherein infrarenal and aortic, common iliac balloon tamponade can be done whilst doing the procedure. There were papers on myometrial excision with mesh repair, and the excision is done, and the part of the placenta which has the part of the placenta and myometrium are excised, and it is repaired after putting a graft. I would like to run through certain cases. A 30-year-old G3A2, 24 weeks, came with spotting, and anomalous scan shows low-lying placenta. She was initiated on conservative management. Now she is admitted with continuous bleeding. Ultrasound shows the grade 3 placenta previa. She was put on bed rest, tranexamic acid. So this is the classical McAfee-Johnson regimen. It is attempted in women who are hemodynamically stable, remote from term, but we should always do blood grouping and cross-matching. Anti-T should be given according to the gestational age. A steroid can be initiated for fetal lung maturity. Tranexamic acid, though humble, it is a very, very good drug, and it stops many kind of bleeding. And always remember, other causes of bleeding should be observed for and treated. For example, it could be a speculum examination can be done, and if present a cervical polyp or erosion can be addressed. And in this patient, she was taking aspirin from a long time, so that was stopped and she was put on bed rest, and luckily she stopped bleeding. So conservative management works well in almost 70 to 80% of the patients, and always we have to keep an open eye and look out for other causes, especially causes like abruption. Those are also should be watched out. Like this second case, second gravida, she came in an emergency department on a classical weekend when everybody is trying to go to home and relax. She came in shock. She had 2 units of PRBC done at outside hospital with NORAD drip and showing an MRI report of grade 4 placenta previa. So all the units were mobilized and cross-match was taken, and 2 units of PRBCs, already she had 2. PRBCs were reserved and issued, and we took her for emergency laparotomy. Intraoperative events, lower segment was not formed, hypervascularity noted, incision was given above the placental margin and the baby was extracted, and manual removal of placenta was done in a piecemeal manner, multiple sutures taken on the placental bed because it was bleeding continuously, and our evil twin sister of placenta previa hemorrhage started. PPH also started, so we gave lot of oxytocics. Blood was about, loss was about 1000 ml. Post-operatively, PPH also ensured. We kept mesoprostol, everything, and you can see how hypervascular the lower segment was. And we were trying to salvage the uterus in very many ways. She had PPH also. So on retrospection, probably before the starting of the surgery, if the patient was hemodynamically stable, we could have attempted to do the uterine artery ligation. It is a simple procedure but very effective. But this patient was hemodynamically unstable, so we were more focused on removing the baby. Once the bladder is mobilized, we can identify the uterine bundle of vessels, then ligate it. But only uterine artery ligation doesn't work well, because most of the times placenta previa gets its blood supply from internal and external iliac vessels as well. But nonetheless, doing a simple procedure will help us in reducing the blood loss to a greater level. The other thing which can be done is, after extraction of the baby, one can always do a tamponade methods. In this case, the placenta was delivered. The placenta was, it was a marginal placenta previa. After taking an incision, the placenta was identified, and see the amount of blood loss will ensure. We are trying to identify the upper border of the placenta. After the delivery of the baby, a tourniquet can be made. This is a simple tourniquet made out of the Foley's catheter by cutting the either ends of the Foley's catheter and placing it from the similar points of the uterine artery ligation on either side of the uterine artery. A tourniquet can be applied using the Foley's catheter, and it will decrease the bleeding till we employ other methods of blood loss. Similarly, if we had an interventional radiologist, we can do the aortic common iliac aortic balloon can be employed right now. A window is created in the broad ligament and the Foley's catheter is placed. From the posterior end, the other part of the Foley's catheter, the other end having the bulb and the valve, can be cut. It is taken from the other end, similar point, that is medial to the uterine vessels, and it can be tied and used as a tourniquet while we do the resuscitative procedures. And the other invaluable tool in our surgical armamentarium should be the knowledge to do the hypogastric artery or the anterior division of the internal iliac artery ligation. It is a simple procedure. In this case, we have taken a vertical incision. Taking a vertical incision helps us a lot because we can achieve a lot more section of the iliac vessels. The peritoneum is open between the round ligament and the infundibulopelvic pelvic ligament. Ureter is identified. A simple dissection with fingers can be done. Ureter is medialized and the common iliac vessels are noted. And the anterior division, we have about 3 to 4 centimeters of the anterior division of the internal iliac available to us for ligation. One can use the right angle forceps. It helps us a lot. And whenever we need not worry that the artery will damage. Artery usually won't damage. The internal iliac artery is identified using right angle forceps, and the ligature can be passed. Always remember the right angle should be used from the lateral to the medial end, because if we are using from the medial to the lateral end, the external iliac vessels, especially the vein, tends to damage. The arteries are very easy and they don't damage easily, but the veins will be damaged easily. So from lateral to medial, the ligature should be passed. and it can be tied. And this should be done on both the sides to ensure less hemorrhage. The other methods are used to, if we can use a Bakri balloon or any tamponade can be used. So learning points from this case was to take a adequate incision, anticipate the problems, call for help, have adequate and appropriate surgical instruments, and enrich one's surgical armamentarium with various feasible techniques. Case 3, this was an elective case. She was a follow-up case. Booked case. She was given IV iron to correct anemia, but she started to bleed at 30 weeks. She was taken up for emergency cesarean section. A colleague of mine was doing, and there were extensive adhesions noted between the peritoneum and lower segment of the uterus, giving no approach to the uterine arteries or even the bladder also. Bladder was densely adherent. We could not separate the bladder, and the transverse incision was given in the upper segment of the uterus, and the baby was extracted immediately. Hypogastric artery ligation was done on one side. The left side could not be approached. See, so much vascularity was there in the lower uterine segment, and the placenta was removed. Luckily, it came out. But following delivery and exploration of lower uterine segment, bleeders of the placental blood were ligated by sutures. A rent in the bladder was noted. It was separated and kept aside. A part of the lower uterine segment was excised to control the hemorrhage, but bleeding was still persistent. As bleeding was continued, bladder was densely adherent to the lower uterine segment. Hysterectomy was done. Bladder repair was done in 2 layers. We gave 3 bloods, 2 FFPs, and about 2,000 ml of blood was lost. Patient was kept on mechanical ventilator and extubated on the next day. This was the rent of the myometrial attached to the bladder, and here only bladder injury was done. It was the dome of the bladder.
Dr. Annapoorna,
Yes,
Annapoorna, we are talking of PPH. That is a different topic, right?
Yes.
So you have to speak basically on APH.
Yes, ma'am. So I will skip this case then. Finally, so to prevent the placenta previa, primary LSCS prevention can be done. Patient education and high risk triage should be done for all cases, and continuous medical education and be readying oneself to prepare for placenta previa should be done. Thank you one and all for the opportunity.
Thank you, Dr. Annapoorna. Sorry, I had to interrupt.
Yes,
Chairpersons, your comments, please.
Yeah, Dr. Annapoorna, it was a fantastic presentation. Of course, you have combined both, no problem. But you are nicely shown all the videographs, which were very interesting. So, of course, nowadays, placenta previa, because of the increase in the cesarean section rate, the placenta previa automatically will be, the incidence will be increasing. And moreover, we are worried of not only the placenta previa, but also placenta accreta syndrome, because the cesarean section, because of the scar, there may be placenta invasion also. So that is why nowadays what we tell to the our postgraduates is, whenever previous cesarean section case has come, first note down where the placenta is. It is anterior or posterior. If it is low lying, whether it has invaded the myometrium manner because of the previous scar. So that everybody as a postgraduate should know it. And one thing I want to know is from you about the legal aspects. If we diagnose the placenta previa, should we take the hysterectomy also, the consent prior, or what should we do?
We as a routine take hysterectomy for consent, sir. In case of emergency as a life-saving procedure, we always take a consent.
Because we don't know which placenta previa and all is well, or sometimes severe PPH where it is very difficult to do internal iliac artery ligation also. Sometimes it is very severe, very difficult. When you are telling, it appears very easy.
No, not at all, sir, not at all.
Because of the hemorrhage areas, all those things. So the prior antenatally is very, very important. So as you told, the hemodynamically, whether it is stable or not. So all these things has to be taken into consideration. Thank you very much. And
Thank you, madam.
I thank Asha Jain and the other committee members who has given this opportunity. Thank you very much, madam.
Thank you, sir. Chandrika ma'am. Chandrika ma'am, would you like to say something?
Dr. Chandrika is my colleague here in GSL Medical College. She has worked with me in many of these cases. Madam, you have to unmute
She
yourself.
is not speaking. Dr. Akkamamba is also not speaking. So thank you, chairpersons. Thanks a lot. And thank you, Dr. Padmaja and Dr. Annapoorna. Dr. Annapoorna has answered most of our questions of PPH as well. Dr. Chandrika, would you like to say?
Hello, ma'am, am I audible?
Yes, yes, you are.
Yeah.
Madam,
Thank you so much. Actually, I think I'm unable to communicate because of some net problem. Thank you so much, Dr. Annapoorna. It has been an excellent presentation. Of course, it was a mix-up of APH and PPH. We both are colleagues, ma'am. We have experienced many cases of antepartum hemorrhage. And I really appreciate and congratulate Annapoorna for giving us an excellent presentation, especially the pics. Thank you, Asha ma'am, for giving me this opportunity to chair this session.
Dear Annapoorna, thank you very much. You nicely covered. Always, when not doing cesarean section, do under midline incision. For doing internal artery ligation, very convenient. For doing hysterectomy also. Take always consent for hysterectomy at time of cesarean section.
Thank you, sir. Thank you so much.
Thank you, madam. Asha Jain, madam, for giving me this opportunity.
Thank you, sir. Thanks a lot, all of you, for being here with us, and gracing the program. And Dr. Annapoorna, the one case where you actually removed the placenta piecemeal, I don't know, there are all experts here. How many would agree to actually removing the placenta piecemeal? Means I really want your opinion. Is it the done thing to remove a placenta?
Ma'am, if we remove it in a piecemeal, it will bleed more.
So that is what your patient went on ventilator.
Yes,
Luckily,
ma'am.
she survived.
Yes, madam. That was the learning point.
So, the PPH panel that we are going to have, it's basically based on guidelines. What you should be doing in every situation. Our panel will speak on guidelines because every one of us does what they can at the time, which may not exactly match the guidelines, or sometimes it may be better than the guidelines. So let us see. So, to all my respected panelists, when we start the panel, I would request you to speak of the guidelines, but also to speak of your own experience when we are talking about it. So may I have the CVs, please? So I would like to introduce my co-moderator, Dr. Sujayasri Sangita. She's an MS Obstetric Gynae, working in Sheshadri Hospital, Palakol, Sheshadri Hospital, Malikapuram. She's the founder secretary of Bhimavaram Obstetric Gynec Society and secretary IMA Palakol. Her areas of interest are laparoscopy and infertility. She has presented many papers and has been the academic organizing secretary of GUSA 2016 and 18. She does a lot of community work, conducting awareness programs, Vikasam for adolescent girls on pubertal changes and menstrual hygiene in all government schools and colleges in the district. This program has received award of recognition by District Lions Club. She has been extremely helpful to me in organizing this webinar because she's done all she can to have all of you here. So I thank her profusely, and then I proceed to the next panelists. Our panelists are Dr. Kavitha Chalasani she's the secretary of Vijayawada Obstetric Gynec Society. Dr. V. Geeta Shri, the secretary of Kakinada Society. Dr. Niharika Allu, secretary Vizag Society. Dr. S. Umashankar, secretary of Guntur Obstetric Gynec Society and a friend now. Dr. Padmaja T, past president of Rajamundri. Dr. Padmavati Granthi, president of Bhimavaram Society. And Dr. Narasavani, vice president, Bhimavaram Obstetric Gynec Society. Welcome, respected panelists. Let us see if we can have a really scintillating session going through the guidelines. Dr. Sujayasri?
Yeah, ma'am, I'm here, ma'am.
All our panelists are present, right?
Yes, ma'am, all the panelists are there.
Okay. I also thank the speaker and chairpersons who are still with us. And we will be speaking on the guidelines of PPH. So these are the panelists, and this is the Searchlight series of webinars. So the first guideline that we are going to discuss is the Green Top guideline, number 52, which came up in December 2016. All this introduction has been actually taken by my previous speakers, that PPH is a leading cause of maternal mortality, the prevalence of approximately 6% and 50% is due to atonic PPH. According to WHO 2014, in India, 45,000 maternal deaths take place annually and 20 to 60% are due to postpartum hemorrhage. Your state, as Dr. Leela said, has done exceptionally well. My state has definitely not done well. We have come down by a few basis points, but we are still much above 200. We are still above 200. So it's really bad. And those who are doing very well need to refresh, and those who are not doing so well need to actually revise what they are doing and see how we can do better. So my first question is, it's open to everyone, anybody can take it. Is it possible to predict and prevent PPH?
Not in each and every case. Some extent we can predict.
Especially so what percentage of cases?
Especially when they are very visible risk factors like antenatal anemia and preeclampsia, or past history like previous pregnancy she had postpartum hemorrhage. These are the visible risk factors where you can think this pregnancy also she might develop PPH and we have to be prepared for it. And other conditions of uterine overdistension like multiple pregnancy or macrosomia. Also, there is a risk for PPH.
Hydramnios.
Hydramnios, yes.
In addition to all these risk factors,
what are the risk factors?
Women suffering from anemia.
But you have been enumerated.
Can I answer?
Yes, ma'am.
Am I audible? Am I audible?
Yes, ma'am.
Good evening, Dr. Asha Jain, madam. Thank you, Sujaya. And thank you all seniors. Very happy to meet you all seniors and colleagues. Madam, you have asked what are the risk factors?
Yes.
Yes. Most of the times, antenatally, we could think of some degree of high risk of postpartum hemorrhage. It is high index of suspicion. Suppose twins, hydramnios, previous history of PPH or grand multiparity or tumor, uterine tumor like a fibroid complicating pregnancy, or things like that. Or if every case, and see, we know there are 4 causes of PPH. Like the tone. See, atonicity we'll be able to predict to some extent. Okay, and the next commonest thing comes the trauma. Trauma is something we may not able to predict much because it's something which happens during the labor. Trauma is something we may not be able to predict, but when the patient is bleeding on the labor bed, or we should be able to judge the site of the bleed and the reason for her deterioration. So high index of suspicion of her deterioration is very important at that point of time. Next, coming to the tissue, retained any case of previous cesarean section. If we give a VBAC or we go for C-section, we have to always think of any retained, which is a possibility. So always
we will take that, ma'am. We will go to that. So how would you minimize the risk? How would you minimize the risk?
Yeah.
Ma'am, to add to that, antenatal risks are definitely important, but intrapartum also, I think whenever you have a prolonged labor in the first stage or second stage, also we should anticipate. So I think all deliveries we should do AMTSF. So that is active management of third stage of labor should be done to prevent PPH. So at the delivery of the anterior shoulder, you give oxytocin and you do a controlled cord traction, and you can do a delayed cord clamping. Earlier, the guideline used to say that you should do an early cord clamping, but now it has changed. So now we can do a delayed cord clamping as long as the baby is doing well and baby doesn't need any resuscitation. So that itself, I think, prevents it most of the cases. We follow it on a regular basis, and in our institute, PPH is actually quite minimal.
Ma'am, shall I answer? Yes, ma'am.
Ma'am, just a minute. Yes, ma'am.
Any pregnant woman is a risk factor for PPH. We should be anticipated the risk factor in any pregnant woman. We are ready with any all gadgets. In addition to generalized women, there are some high risk factors, like already ma'am said, Kavitha garu, like over distended uterus or overstretched uterus, or any sick uterus. So over distended uterus means multiple gestation and hydramnios or polyhydramnios and macrosomia, and overstretching means high parity. And another thing is prolonged labor, when there is a history of prolonged labor, exhausted uterus. And also another thing is when there is prolonged induction of labor. So all these risk factors are there. So not only with these risk factors, and also even every primary, we should cautious of the PPH, because there is some inherent quality of the uterus. That is, there is also recurrence of the PPH in second pregnancy or third pregnancy. So we should keep in mind all these factors before dealing with a pregnant woman while she is partial, that is, she is in labor. And another thing is, as already said, prophylactic uterotonics and prophylactic measurements, and all those things are also helpful. And this process of minimizing risk should be started from the antenatal leave. That is, should be treat the patient anemia first, whether she is updated to the normal hemoglobin or whether she is below the standard hemoglobin levels. Then comes to the during delivery. During delivery, we should keep very keen watch. After completion of the delivery, we should put our hand on the abdomen, whether it is contracted. Previously, in olden days, it is described as a cricket ball hard. It is a cricket ball hard or any softness in the uterus. Another simple thing is we should see once we
examine placenta
and relaxation. We should see any gush of fresh blood, whether it is bright color or dark color. So after completion of the process of labor, while we're leaving the labor room, we should once check for abdomen and for PVH examination. So if it is there, we should take alert and do the needful things to save the woman.
Thank you, ma'am. Dr. Kavitha, just a second. Dr. Kavitha, I want to ask you, what is the contribution of anemia to PPH?
When there is antenatal anemia, there is a very high risk.
What percentage actually? How? see, there is data that 60% of our reproductive age women are anemic.
And around 30 to 40% of anemic women have PPH. And again, the severity of PPH depends upon the severity of anemia, that the hemoglobin, the lower the hemoglobin level, there is an increased risk of PPH, and the severity is also higher, ma'am.
So that is why in the guidelines, they have said that the first thing that you can do to prevent PPH is to treat anemia. Correct anemia. We are actually not paying attention. Even in this panel with such learned faculties, everybody goes directly to labor, right? Everybody jumps to labor that, we'll give uterotonics, we'll do this, we'll do that.
In the antenatal period, hemoglobin is checked every trimester, ma'am. In case there is a low hemoglobin, the mother, the hemoglobin level is not getting, if there is like around 9, more than 9, and the hemoglobin is not improving with oral iron, we have to give parenteral iron to increase the hemoglobin level. Our aim at the time of delivery, hemoglobin should at least be 11 grams per deciliter.
That is the most important intervention that we can make, because in my state, we have a lot of sickle cell disease and sickle cell anemia, and we also have a lot of thalassemia. Yes. And that is such a big contributor. Yes. So don't actually forget anemia. We all do the interventions as per guidelines, but the first intervention is, it's important. We cannot let go of it. Dr. Padmaja, you were saying something? Before I interrupted.
I was just saying it should be a routine habit after delivery of baby to check the placenta once, if all the lobes have come. That's a very important point, because the patient may not show immediately. She may present as delayed PPH, secondary PPH.
Yes, ma'am.
Thank you. So,
ma'am?
Yes?
Yes, you are right. In sickle cell anemia, thalassemia is very prevalent in your state, but in our state, iron deficiency anemia is very common.
Yeah.
And even not only in pregnancy, even menorrhagic people, we are used to get 7 to 8, even 3-4 grams HBs. We are
who is speaking? Ma'am, who's speaking?
Yeah, ma'am, please click on the video so we can see you, ma'am.
Yeah. Okay. Yeah.
Okay. Yeah, because otherwise we don't know who's speaking, ma'am.
Yes. Is it okay?
Yes,
Yes,
ma'am.
Yes, ma'am.
Yes.
So, Jia, please put on your video as well. Requesting all panelists, please put on your videos.
Yeah, for each and every anemic case, we are planning a peripheral smear, ma'am. In peripheral smear, we are getting reports about normocytic, normochromic iron deficiency anemia. Then only we are going to give parenteral iron and all these things. With these things, we have improving her HB. Not only in pregnancy, even 3-4 grams also we are treating these ladies. So iron deficiency anemia is very common in our area.
Thank you, ma'am.
Another thing we have
my
to make
question
note of
is,
the patient compliance is very poor for iron. So we have to motivate them and sensitize them to the because that is one important reason we tend to over.
Means, is the dose of oxytocin different in a vaginal delivery and in a cesarean delivery? In cesarean, we don't know, the anesthetist is giving it.
Yes.
But is the dose different?
Ma'am, in our institute, the anesthetist generally gives 5 units slow IV instead of the 10 units IM. So they give 5 units.
So is there any role of methyl ergometrine with oxytocin? Is there any role?
First line is oxytocin, ma'am.
Oxytocin.
In case
No,
there
no,
is
means in a high risk case.
high risk case. If
Ma'am,
like,
if preeclampsia has
is not a case of antenatal.
What is your experience with carbetocin?
Carbetocin
Yes,
acts for a longer duration, ma'am, though not like immediate action. It's a long-acting oxytocin analog.
Means
It's a second line
are you
ultrasonic,
people
ma'am.
using it?
Yes,
And
ma'am.
what is
Yes,
your
ma'am.
response?
We are using.
We are
Yes, ma'am,
using.
we are using.
Like after the initial 5 units slow IV of oxytocin, then we're giving carbetocin now.
Okay, means you are using both.
Using
You're
both.
not using oxytocin.
Yes,
No, ma'am.
ma'am.
No,
If you
ma'am.
can,
I am
ma'am,
if my patient is affordable, can afford a 500 rupee carbetocin, I give only carbetocin and nothing else. And usually they don't need anything else.
Active management
Exactly.
of third stage.
Yes.
We give
Dr. Padmaja?
oxytocin at the delivery of the.
madam, I would prefer to give oxytocin if the uterus is still atonic. Then certainly I will go for carbetocin.
Dr. Narsavani?
When carbetocin can be given alone, it can give excellent results. But the studies are not still going on, but there is no recommendation by our guide.
It's only a matter of cost.
Migo has
madam.
given.
Madam,
Yes,
let us
Dr.
say-
Padmaja.
Yes.
Yes, Dr. Padmaja.
Only recommended
Just a
in the
minute.
access of active labor management of the third stage of labor. But it's
Madam,
an excellent.
carbetocin we've been using,
I'm using
madam.
that
What
one.
we need to do is, even at section with the as we are delivering the head, if
Yes.
we give it slow IV, gently take out the shoulder and concentrate on mopping the face, clearing the eyes, the nostril, the uterus slowly retracts and the baby gently comes out. And along with that baby coming out, watch and wait for the cord pulsations to stop. And by the time we clamp the cord, hand over the baby, the placenta follows and the uterus retracts with it. So what
Yes.
I find it working is we should not be in a hurry.
Yes.
Then it
So
will slowly retract and work, and then it will work, and it is only for singleton low risk people. Don't use it in polyhydramnios, don't use it in twins, don't use it in anything else, because there are not adequate studies on that. Singleton low risk, it is working very well, and we don't need to use any misoprostol or anything after that.
Yes.
So that is the beauty of the molecule.
Yes.
So, and what is your opinion about tranexamic acid?
We are routinely giving
Definitely.
tranexamic acid 1 gram IV before the start of section.
But is useful only within 3
No,
hours. of
madam, not
delivery.
routinely using, madam. If
I am
we
not
feel
using
there is some
routinely,
placental
ma'am.
blood,
What it is like what it says is, even if we can decrease 50 ml of blood loss, it works for the woman, madam. Our women, I feel we should not lose blood because synthesizing blood is so difficult.
Actually, rather than giving tranexamic acid by direct IV, we're just putting it in the bottle of RL or normal saline which is running.
Dr. Geeta Shri, you haven't said
Can we
anything
use
for quite long. What is your opinion about tranexamic acid?
Tranexamic acid is very good drug, madam. We are using in anticipating case of PPH. In case of anemia, we are giving before the incision of cesarean section, we are giving 1 gram IV. Just it is controlling very much, and we are getting so much of hemostasis. And so the tranexamic acid, it is working very well, ma'am.
I don't use on a regular basis, only if there is traumatic PPH or in C-sections. If after uterotonics it's still, then I use. Otherwise, I do.
madam, even I don't use it routinely. It's basically antifibrinolytic. So if there is some placental bed bleed, which might not be responding, then it has more
We are
action.
anticipating means, ma'am, if she is having preeclampsia where the oozes are more, when we are giving incision, if she is having so much of ooze, and we can anticipate, she may have some problem with the bleeding. So in those cases, we are recommending, ma'am.
You know what? The guideline says you should give 1 gram IV. That is the guideline. So
Yeah,
we
ma'am,
come
1
back
gram
to
IV we
what
are giving,
we
ma'am.
are doing and what is the guideline.
Delivery of the baby, but not afterwards. Only within 3
We
hours
have
of
some
delivery.
input from Dr. Umashankar sir also. So you can also contribute.
Yes, ma'am. We actually use tranexamic acid in cases where we have preeclampsia and there's multiple oozes are there. Rest of the cases, routinely we don't use, and we'll be using 1 gram of tranexamic acid also. Here, I just want to bring to notice, because what are the risk factors for postpartum hemorrhage? One more thing is, and especially if we deal with patients who are elderly, and at the same time, patients who are having amenorrheic patients. So the uterine strength itself is not very good in this uterine musculature. These are the special two categories of patients which are prone to PPH, and you must be knowing if the patient has conceived through ART. These two types of patients you should consider and then go ahead and you suspect a postpartum hemorrhage in these patients.
Sujay, you want to take it from here?
Yes. Next question would be, how would you manage a case of PPH? What would be your protocols that you put in place?
Again, depends on the severity of PPH. Severity of PPH means, though it is immediately, we cannot exactly assess the blood loss. We can even see how hemodynamically stable the patient is. And the first line of management would be oxytocin and then methyl ergometrin in case the patient is not having preeclampsia. And then PGF2 alpha IM 250 micrograms, that is prostadin. And then rectal misoprost 800 milligrams. These are the first line. And to achieve the tone of the uterus, because most of the cases of PPH are because of uterine atony.
And sometimes we are unable to assess the blood loss as such. So I think it helps to have a pictorial, a chart or something in our labor rooms, which can tell us which, like one kidney trace, how much, and things like that, so that at a glance you will be able to assess. Because sometimes even though patient is hemodynamically stable, she's actually lost much more blood. So actually having tachypnea and tachycardia are more than 1,500 losses already happened. So I think
not tachypnea, ma'am. Hypotension is initially there, and even tachycardia also starts a little early.
Yeah.
Dr. Uma, you would like to add something? Dr. Uma Shankar?
More or less the same thing, madam. Nothing much to add on that. I think that should be okay.
So, when you are managing PPH, these are the factors that will actually save you in case something goes wrong. You need to communicate with multidisciplinary care, communicate with the woman, and communicate with the family. While you are managing the case, unless this part is taken care of, something happens. Somebody has to be designated to actually do this work. Otherwise, what happens? They don't know what is happening. Everybody is running about. And something goes wrong. They come to you with a court notice. So this is also part of the protocol, that when you identify that it is severe or your patient is in some kind of trouble, the communication also is equally important, along with managing your PPH. That is why I actually brought this guideline forward, that, there are certain things we are all doing, but still so many of us are in so much trouble.
Yes. Ma'am, I think having a skill drill regularly, especially with your team, the core team, and designating who's going to be the team leader in case of an emergency, who's going to do the record keeping, who's going to communicate, who's going to get the blood. So actually having them as a drill on a regular basis helps when it's suddenly you're faced with these emergencies. So I think
one of our team who is along with us, that is a staff, a female staff, who is accompanying in the process of the labor room, she has to explain better. If there is nobody to give a communication to the family and the parents, it is better to send a staff, a female staff, who is seeing from the beginning what are happening in the inside the room, what is going there. So what are the importance of blood and blood products? Are any anesthetist, helping anesthetist also useful in communicating the family and parents?
Dr. Sujaya?
Yes. So when a patient presents with PPH, so who all should be involved in this procedure? Whom would you want to intimate first?
I think the most important person would be an anesthetist, somebody to procure blood, and staff to help you with the medication injections, and somebody to hand out all the medications and the instruments that you would need to help out. So I think having your regular team should be there.
And also keep informed a close friend or a senior gynecologist who could be on help.
Yes.
Because we may have to go for surgical intervention or anything. Always it
So
is
then
better
the
to keep
medication
them
is like-
informed.
If there is minor PPH, blood loss of 500 to 1000 without shock, what are the steps that you're going to take?
First, the 14 got the cannula, ma'am, a large bore cannula, and then start off replacement of fluid with crystalloid solution, and then give all the uterotonics, whichever we have thought about till now, and then send, when we put in the cannula itself, we can send blood for again cross matching, and then complete blood counts and coagulation profile and fibrinogen levels. And in the meantime, the monitor has to be running continuously. The pulse, PP, respiratory rate has to be monitored, and then fluid replacement started and blood to be asked for.
Ma'am, I think very important.
I think the first few minutes are very crucial. We don't allow the patient to keep, the first few minutes are very crucial for all the resuscitative procedures.
Even it is a minor one, we should continue the oxytocin drip in a diffusion manner until that golden hour is completed.
Ma'am, I think another
the patient to the room, to the ward. So we should continue the uterotonics for at least 2 to 3 hours after entering the ward. And also close monitoring is important for that golden hour of the PPH.
And important is an empty bladder, ma'am. It's very important to put in a catheter.
Madam, if we have a minor PPH, madam.
Very
Yes, sir.
important.
Yes, Dr. Uma.
If we have a minor PPH, especially I've seen, because most of my cases are LSCS, we just put a condom catheter inside to prevent further deterioration. Hello?
Yes, sir.
Yes,
Yes,
sir,
sir,
you're
we can hear you.
Yeah, to prevent further deterioration, we just put in immediately a condom catheter with other restrictive measures so that it won't deteriorate. Once we
No,
see
that is for a
after that.
cesarean. If it's a normal delivery,
Normal
if
delivery
it's a
also,
vaginal delivery,
Can keep
we do the same thing, madam. If we suspect anything, before we start, we get everything to stop local pressure.
Saturation
Condom
ఉంటుంది.
catheter is always kept at hand in our labor rooms.
one thing I want to ask you, have any of you used Dr. Manekar's cannula? PPH cannula?
SR cannula we are using.
SR cannula we are using,
SR
madam.
cannula we are using.
It's almost similar.
It works?
Yes, ma'am.
On basis of negative section. Yes, it works.
Okay.
Ma'am, I think I want to add the guideline also says warm liquids, and keeping the patient warm is a very, very important point, which I think most of us forget. So having either a warm crystalloid or at least put a warmer, so it prevents acidosis and further deterioration fast.
One more thing I want to ask you, how do you people warm blood? Blood has come from the blood bank. It's cold, right? How do you warm blood?
We are keeping it outside.
Madam, the anesthetist usually tells us not to warm it because it's
Not
an
warm it,
emergency
yes.
thing.
So
So
just
we
to
give it immediately.
Not
recool
warm
it,
it,
ma'am,
ma'am.
just wrap
Just to
it
keep
in
it
a,
outside.
keep it outside.
Keep it
ma'am,
outside
then.
the AC.
Outside the
Keep it
AC
outside the
for
AC.
some time.
Usually
So
it works.
previously, madam, when my mother was practicing and all, they used to have water baths. So lukewarm
hot
water, they
water,
used to put the blood and then they used to give it, madam. But now the anesthetist says you shouldn't be warming it, to do it directly, is what
Yeah.
they're doing. Yeah.
So what we do is, we make the attendant put it under their clothes next to their body while they are getting it.
Yes, ma'am. Yeah, that is
know,
a
and-
good option.
That is the
Good
way.
option.
So it's close to the body. It gets warm enough, 10-15 minutes, and it does the trick. So just thought I would share this little bit.
Yes.
Yes.
So now we have the major protocol. It's more than 1,000 ml bleeding. Now what are you going to do?
So first resuscitation is the standard thing, madam, airway and breathing. And then you start your cannulas.
Two cannulas, large.
Two wide bore needles you have to keep.
Two wide bore.
Which color cannula are you going to use?
Gray.
Green color.
Gray.
Number 18 is ideal.
Green color. Green is the
16
one.
or 18.
Green we are keeping, ma'am.
Green
Yes,
is 18.
14 guys.
Green
Green,
is 18, madam.
18. We have to
Yeah,
still
14
come
gauge
down,
needle we
18
have to
is
keep,
ideal.
ma'am.
madam. Yes.
Gray is 16, I think.
14
We
and
use
gray.
gray, madam.
14 or 16 is ideal, ma'am.
And we ask anesthetists if possible to put in a center line also, because we always have anesthetists at our disposal. And then we start giving transfusions of fluid. First, as we discussed earlier, crystalloids, and then we look for blood. Here in the guidelines clearly says HE, the hydroxyethyl starch should not be used, and this should be made note clearly to all the audience.
What should not be used?
Hydroxyethyl
Starch.
Gelatin can be used, not starch.
Dr. Padmaja, would you like to add something, ma'am?
18 can second line is especially we have to start second line, not only the
Yes, ma'am.
initial
Two
line.
IV lines.
Two IV lines and send for cross matching and be ready with the blood bank and all coagulating profile. All these things have to be prepared.
One thing I want to ask you, if too much of crystalloids have been given, what happens? Means the outer limit they say is 3.5 liters.
Yes.
But supposing, you haven't really counted and your staff has given more, what happens if you give too much of water?
Cerebral
The
edema.
coagulation factors will go down. Dilutional coagulopathy.
Dilutional coagulopathy.
Yes, so that we have to actually keep a record of. And when I did my critical care course, they said not to exceed 2.5 liters.
2.5.
Madam, I just looked up. Green is 18 gauge with a flow rate of 103 ml per minute if you open it fully. Gray is 60 gauge with 236. Pink is
Red
20.
is 20.
Pink
14.
is 20.
Pink
is
is 20.
Red is
Pink
14.
is 20.
Orange is 14 with 270 ml per minute of fluid rate. So we need to have at least green on a routine basis and gray as a standby.
Gray.
Yes, for Indian women, green is easy.
Green
Because
is
we may
18,
not
ma'am.
get-
Gray is
Yes,
16.
That's
even
what
with
we use most commonly.
hypertension, we cannot get that large bore needle. Hypertension and tachycardia, we are unable to
Yes.
insert
Yeah,
those.
the veins are collapsed. Yes, yes.
Yeah,
So gauge, we should keep a gauge 18 minimum. 16, of course, better, but many times we will not be able to pass 16.
Is more important.
Are you going to look after the massive transfusion protocol, or you're going to get help from a hematologist or critical care person?
The
If
basic,
we have the
we have to
access,
do, ma'am.
definitely.
No, what I'm saying is the patient now has bled 1.5 liters. It's a major bleed. You have to give a massive transfusion protocol. So will you do the massive transfusion protocol yourself, or you'll get a help from somebody? Practically, in your unit, what do you do?
Whenever we give massive transfusion,
The ratio should be 1:1:1.
take
That's most
advice from
important.
a experienced
Absolutely.
1:1 of what?
PRBC,
PRBC,
and one is platelet.
platelets. You have to maintain the platelets above 75.
Also, we should take advice
What
from
what is your opinion of cryoprecipitate?
Cryoprecipitate
the
suspicion of connective coagulopathy.
If we think of things
Only
like
if the
hemophilia or
fibrinogen
some-
level is less than 2 grams, ma'am, then cryoprecipitate.
And
We have to
also
give, or
continue
if there is a abruption or amniotic fluid embolism, then we have to give cryoprecipitate.
Actually,
along with
okay,
platelet.
factor 8 concentrate, all these are things
Plasma and
which are different actually.
So what about FFP?
FFP is given when there
We
is
give routinely when we need massive transfusions, madam.
less.
Never
In the
we give
ratio.
massive, we give.
INR ratio is less, that is less than 1.5.
What is the level of fibrinogen to be maintained?
2 grams.
250.
More than 250 mg or
250.
1.5 to
Normal is above 400, madam. Minimum it should be maintained at 250.
350.
In what conditions would we have to transfuse platelets? I think Dr. Niharika mentioned.
Yeah, if the
Yeah,
platelet
minimum
count is less than
75.
75,000. Yes.
75 minimum we should.
Even 50 can be.
I think we've covered this question.
But in case we have to go for surgical intervention, general anesthesia is preferable, because we will be able to maintain the hemodynamics better, if possible.
Yes.
So, Jaya?
Yes, ma'am. So, is there a role of factor 18? If so, when would you recommend the usage of it?
Factor? Pardon?
Ma'am,
8, no?
Only
Not
if you've
7, I think.
exhausted everything and
No,
it is
ma'am,
available.
I think this goes to the hematologist.
Yeah, actually, it's very expensive.
It is, and if it is available,
Very expensive, not available as well.
then maybe.
In our setup, it is not possible.
Factor 8?
Actually, a lot of people here don't have access to a hematologist, ma'am. I think the only one we have must be in Vizag and Vijayawada. I don't think
Vijayawada we do have.
Madam, we rely on our anesthetists.
Yes, exactly. For massive blood transfusion, life-saving massive blood transfusion, we don't need to rely on hematologists, madam. If a good anesthesia or critical care, more than enough. Enough.
And I don't think we should wait and delay it. Doing
Because
it
now all
faster is
gynecologists are also well trained to handle the.
Are any of you using the MEOS chart?
Yes, ma'am. Yes, ma'am. In my hospital, it is regular. So we always have, in all the labor wards, we have a partogram, we have a MEOS. We do carbitocin, delayed cord clapping, everything. Everything according to RCOG.
So that is why you people have such good rates, no?
Yes.
That
We
is why
hardly
you have
see
such good
PPH,
rates.
ma'am.
Yeah. So I want somebody to describe this, for the viewers who are there, what is a modified early obstetric warning score? What does it have? If somebody would please describe that.
So there's an orange and red in it, 2 colors. And we have all the patient details in it: pulse rate, respiratory rate, blood pressure, patient general condition, response to pain, neurological condition. Then we also have the patient color, how she looks. And all of these they're all there in the, like you can just point out and you will be either falling in an orange or in a red. So depending upon your orange score and red score, you can intimate your senior members, especially this basically for the staff, nursing staff, so that in case in the ward or in the labor ward, they notice when they are monitoring during the labor or in the postpartum period, if they pick up on anything, they can immediately alert. It is basically to alert the senior faculty members.
Okay. Anybody else wants to add something to this?
Madam, for the initial assessment, MEOS or modified MEOS, anything will be a little cumbersome. So we have the modified SOFA score, which is very quick actually.
What score?
That is just the systolic blood pressure, the respiratory rate, and the mental status. Those are the 3 things what we consider there. And the systolic BP, if it is less than 90, it is alert. And the we can, if it is before we even the pulse rate, if it is above 110, it is alarming, and the respiratory rate above 20, alarming, and the mental status, if the patient is not alert, it is alarming. So this is very, very simple.
But if the mental state is not responding, so she has already gone into a very irreversible state.
Madam, not the stage of not responding. If I can add, she's not alertly talking.
Yes,
Madam. Dr. Annapoorna wants to add something.
Madam wants to tell about quick SOFA score. Actually, SOFA score is done in the ICUs for sepsis and organ failures, madam. It is not applicable to our MEOS score. It is for a very terminal cases wherein sepsis and organ failure has set in. MEOS score is a very early warning sign where it can be done by any person to alert the obstetrician. I think that is the basic difference.
Okay.
Okay. Thank you.
Sujaya, please take these.
Yes, ma'am. So what would the role of an NF in the management of PPH? How would he support the obstetrician?
Very crucial, ma'am, for putting in the cannulas, for volume replacement, for giving uterotonics. And in case of any surgical procedure is required, administering anesthesia. Very crucial.
It also help us with the communication with the attenders. I think We are very
Yeah.
Yes, we can rely on a medical person to actually give out the correct information instead of letting a staff or IMA tell them some, incorrect information, what they perceive is correct.
He's the one only backbone at the time of that crucial period. It is even a third person.
So how are you going to
person.
arrest the bleeding? I think this has been spoken about. We give the drugs and then you put in the condom catheter. What else can be done? What are the other mechanical strategies that can be used?
Simple is the bimanual return message, madam. Bimanual, that is the compression tablet, what we use routinely. Compression tablet, we put our fist inside and put the left hand over the abdomen and flex, keep the anterior, just compress the anterior and posterior uterine walls, which we do routinely in the vaginal deliveries. That is the simplest thing which we can do. And it should
How long can you do it? How long can you do it?
Madam, it is the immediate measure which we do, soon we identify. So many times the uterus might take some time to, because it's natural property of the uterus to contract. The mymetal fibers might take some time and they might contract majority of times. And if they don't, if the uterus still remains atonic, then we go for the other measures. This is the first simplest measure. And also we also have one thing. If the bimanual compression has decreased the flow, we can keep in mind that probably the compression sutures will have a benefit. So that is also a thing which we should, because step by step we should be thinking what next to
that's
do.
what the next question is about. If your mechanical and your pharmacological agents fail, then what next? How would you surgically manage the patient?
Mechanical and pharmacological fail, then balloon tamponade, even if that also fails, then surgical with compression sutures.
If the tamponade fails, why can't we try SR cannula? Madam, anyone is trying SR cannula?
Yes, we are all discussing about only atonic uterus. We have to
look at other causes
traumatic.
also.
Traumatic. That is there. Many times referral cases they miss. The uterus will be well contracted and the patient will be gushing from down. And many times it is a bilateral cervical tear, which we can very well
suture under anesthesia.
Yeah, exactly. We can very well do it. Proper gynecologist can do it very well. And also sometimes we may not be able to, the cervix might be normal, but still the vitals can be deteriorating. And the uterus will, when we should think of a broad ligament hematoma or things like that, which we will feel like a vaginal fullness. Or still if there is bleeding, like suppose still bleeding is from the uterus, but the cervix is normal, we have to think of rupture. So these are the step-by-step thing. So
actually, if we have to differentiate between, if we like a simple measure, if we have to differentiate between uterine atony and traumatic PPH, the color of the blood gives us a little indicator as to if it is traumatic PPH, which is coming from the fresh blood vessels or uterine blood.
No, only placental bleed comes blackish color.
That's what
fresh atonic PPH, it is red.
Yes.
Because it doesn't take time to clot. Only placental bed bleeding gets that little darkish shade.
It is a traumatic laceration. It's a fresh blood, bright in
so
color.
That is a
bright
very
in color.
important
Traumatic
point.
blood.
Look at the cervix. Look at the episiotomy stitch.
Fresh from a cut wound. It's a traumatic
Now,
lesion.
how soon would you do a hysterectomy? If the patient continues to bleed, would you do it early or would you do it late?
Early.
First of all, we have to counsel the patient and the attendants about the step-by-step what we're going to do, madam. Soon going to the theatre. We always have another option to laparotomy.
If it is deteriorating condition, it is better to do earlier. After informing the parents and family. It's always better and the best to do earlier. If the patient is deteriorating, not stabilizing, by all the gadgets, all the tries, bimanual compression, and putting anteroposterior compressing sutures and tamponade techniques.
Ma'am, I think we forgot one important thing is the aortic compression. We need not even do a laparotomy. We can just do an aortic compression. We can give with our fist. that itself can help out.
Yes.
Till all the medication works.
Exactly at the level
All
of
right.
umbilicus, if we give a tight pressure, that is easy in lean patients, Dr. Niharika. In
Yes,
little
true, I
obese
agree.
patients, again, it is
Not
difficult.
for everyone.
But this is something which
What are the
any
causes?
of our Aya
See,
can do.
come on, now we have to be really fast. How are you going to manage? First thing is, what are the causes of secondary PPH?
So
Most of
retained
the
products of
causes-
Retained placenta
causes is
mix.
Infection is the most common cause of secondary PPH. Either the infection because of the uterine wound or inside the endometritis, or sometimes there may be any retained tissues, that is retained placenta or placental tissues, membranes, etc. So most
Or
common infection is the
somebody might have left
Maybe
some foreign
malformation
body and
or
forgotten
it
to remove.
Yeah.
Maybe due to infection also.
Infection
So then
is most
basically it is infection or placenta.
pleasant.
Right?
Yes.
Yeah, only two.
Many times it is the infection of the placental site, madam.
So what,
The
are you going
placental
to do
bed
a
infection is
DNC?
very common.
If there is a piece of placenta there and that uterus is so soft, would you do a DNC? Would you take it out?
We have to do an ultrasound guided curettage under antibiotic cover.
Very blunt. The curettage should be very blunt. The large one we have now, just with serrated margin. The very
So it should be a gentle
blunt
curettage,
curettage,
not a blunt curettage. It should be gentle. Never put
gentle
any-
and blunt.
What is your opinion of a suction evacuation? Instead of, curating, you just put in a suction and take the
Placental
tissue.
bit which is adherent might not come with suction, ma'am.
But first we can attempt the suction evacuation. Then if it's not coming, you can put in a soft curettage, not a blunt and sharp one. And also it should be under guidance of a senior.
Because the uterus is
should be
very
ultrasound
soft and
guided.
there is a risk of
Ultrasound guided is ideal. Ultrasound guided is ideal. No doubt.
Madam, in my practice, we usually do it with ovum forceps and
Ovum
ultrasound guided.
forceps. Ovum forceps is ideal, sir.
One more thing is
Sponge holder also.
Products of conception for a long time. We should be ready with blood products also, because whenever we pull the products, there will be tremendous hemorrhage. We cannot expect an answer sometimes, but we should ready with the blood also. So it's when it takes long time to come out, it is always very important. One is infection, second is retention products also causes AV malformations. So retention products of conception removal is also very problematic. Sometimes you should anticipate and ready with blood. Even it's a simple process and an easy process.
Madam, AV malformations require special mention, madam, because we have seen many cases, especially they have to be treated with methotrexate, and we should not give any curettage because they're going to be torrentially and it's very difficult to control.
Yeah.
So when you see AV
I think
malformation,
in case of retained bit, MRI will be able to differentiate what is the depth and if there is any malformation there, AV malformation.
No,
Even
AV
ultrasound
malformation
Doppler
is
will be
best
able
seen
to
by
help
ultrasound. By
First
color
Doppler will
Doppler,
do
it
it.
is best seen.
The degree of
Doppler
placental invade, the bit which is invaded, or if there is any.
Yeah, you can make that out very easily on a 3D ultrasound with Doppler. So that works. I was just waiting for somebody to bring up methotrexate, whether it works. It does work.
It does work, madam. It does work.
We
Only thing we have to
now
we need
we
proper
also
monitoring of the
have to
counts.
have documentation.
In retained products of conception, there is no role for methotrexate and no role for beta-HCG evaluation also.
Ma'am, in
Methotrexate does have a role, ma'am.
Does have a role, ma'am. There is a role.
No need beta HCG, but methotrexate does have a role.
What about debriefing? What is debriefing basically?
Ma'am, I think telling the women and her partner and the immediate family members about what all went on and how it was handled and what is the outcome of the situation. So explaining them in detail is very important, because when something like that, such catastrophe occurs, they are not mentally prepared for it, because they have just come in for a normal delivery to just have a baby, and then all of this happens. So it is very essential, and I think also decreases our risk of a legal problem when you actually sit down and debrief, because then they know that you've tried everything, you've explained everything, transparency is there, and they actually appreciate your efforts. In my institute, we allow a partner to stay on a lot for the delivery. So it is a very, in fact, I used to be worried initially to let them in, but since I've started, I feel they appreciate the efforts more.
I think it is better to keep one elder people of the family, female attendant, rather than partner, because they are very anxious and very
not necessarily, ma'am.
Madam, one more thing, madam, I just want to tell you about the education. So in our hospital, we have teaching to the patients before 7 months and after 7 months. After 7 months, we teach them how to handle the baby also. There's a classes given by a gynecologist. And at this point, we also tell them about PPH slightly so that they know such a thing exists and they have to be careful. And that's why they're more cautious in our institute when they come for delivery. So this actually helped us. The briefing starts from 7th month itself, that there can be complications during delivery and they have to be handled. And some of the parents, husbands actually ask us, how do you handle them? And we explain some of the steps to them long before the delivery actually occurs.
Actually, medico-legally, that is the safest way.
Yes, ma'am.
Because when a patient is in crisis, then your explanation is not considered informed consent. Because the patient is not at that time in a mentally sound state of mind. So it's great work that you're doing, Dr. Umashankar. And Sujayasri?
Yes, ma'am.
Please take over.
Ma'am, actually, ma'am, I have an emergency surgery around the corner. I was wanting to log off.
Okay.
Thank you, ma'am. Thank you so much.
Thank you. Thank you. So, when are you going to give FFP?
When the massive blood transfusion more than 1.5 liters, it is a rough estimate. Many times we may not be, it is difficult. The estimation of the amount of blood loss is very vital. Whenever we think that the blood transfusion is going to be massive and the PPH is massive, we have to keep ready with the FFP, because it is a nature of the quality of the blood to keep on trying to clot, and we get exhausted of, the body gets exhausted of all the coagulation products. We need FFP
And if
in the ratio of 1:1:1.
PTINR is more than 1.5, then we have to give.
INR ratio is more than.
And we don't have the time to check or wait for the INR reports.
No, ma'am. Once the reports have come, if it is more than 1.5,
Yeah.
it's definitely indicated.
Yeah, definitely indicated, of course.
But even before that, when she has bled heavily, you're going to do that.
Yes.
So then this is the tone, thrombin, tissue and trauma. And the cervical tear has been mentioned, but the episiotomy and perineal laceration has actually not been mentioned. Yesterday, I got a patient who has delivered 2 months back. Her episiotomy wound is still infected and bleeding. It's not very common. She delivered somewhere else and she came to me yesterday for the first time that, there's bleeding and burning over there.
Madam, I want to tell one word. Most of the times, the perineal, the posterior, the RMLA, what we give, or the extended perineal tears, if they're posterior, they don't bleed that much because it is the bulbospongious and the transperineal tear. But if the tears are paraurethral, they bleed continuously. And it is very difficult to suture them. That's very important because the supply is from the end artery, that is the pudendal artery. There, the bleeding is continuous. It is difficult to arrest that paraurethral tears.
Very true. Very true. So now this is the summary of the fluid therapy. Maximum 2 liters of crystalloid, maximum 1.5 liters of colloid, and then blood, which you've already discussed. 1:1:1:1. Okay. Now we have the ACOG guidelines, which are just the same thing, except they've been talking about the bundle. Are any of you dealing with it with this approach, bundle development? Can't hear you. Who's speaking? I don't know. Can't hear.
A specific protocol, we should follow a specific protocol in every maternity hospital. So that might be the bundle approach. That contains.
So that is readiness, recognition, response, and reporting. So I think we've discussed everything. Now I think I'm going to stop the sharing and we will be basically talking about our experiences before we actually finish. This is the typical Beeline suture that is given, and then the Heman suture. What's the difference between the two?
Beeling suturing is the anteroposterior, and there is a myotomy. That
It's
is
vertical.
Whereas other one, there is no need of any hysterotomy.
Hysterotomy not required.
Not required in myomas.
Okay. So if there is an adherent placenta, where should it be managed, and what is specific about an adherent placenta?
In creep syndrome like diseases, so we should always refer the patient to a center.
Madam, antenatally, we will be able to diagnose an ultrasound by absence of the retroplacental sonolution zone and plenty of placental lacunae, which we should have high index of suspicion. And if the patient has history of cesarean sections, if the patient has a history of multiple abortions or DNCs, period especially, then it's a high index of suspicion when we have to think of adherent placenta. Means most of the time it is not a diffusely completely adherent, a patch of placenta will be adherent, either at the scar or the fundus where she had repeated curettages. So we will be knowing on ultrasound even that part of placenta which has been adherent. And of course, the Doppler.
My question to you is, would you take it out? Would you take out the placenta, or you would remove that portion of the uterus, or you would do a hysterectomy?
It is always very important. Do not touch the placenta whenever it is adherent, either anteriorly to the bladder, posteriorly. It is more important. If it, opening of the abdomen, if you see any signs of adherent placenta, if you are not able to deal with this situation, it is better to close the close the abdomen and shift the patient to the higher centers. Unless you put a hand on the placental side, there won't be any bleeding. So better to close the abdomen and send her to a referral levels and a tertiary care level.
Dr. Uma Shankar?
Yes, tell me, madam.
Sir, I wanted your opinion. Because, some people say that you can take out the portion of the uterus that is, adherent along with the bit of placenta, and you close the uterus and don't do a hysterectomy. What is your opinion about this?
Madam, it depends upon the location, madam. If you can get a flap, maybe you can go ahead. But if you don't get a flap, it is better not to do it. Instead, you can take other procedures.
Now, to all the panelists, would you want a urologist there if the bladder is involved?
Oh, definitely, madam. If we have a urology friend, we would be happy.
Urologist mainly, I think, used to check about the ureters. But we, as such, we can also repair the bladder.
We can also repair the bladder.
Yes.
If it is only
Because
for the.
if we just put into our audience that we can do it, I think we may be able to do it. But the role of urologist will be more to the ureters. And I think the closing technique should be taught to our juniors very well about bladder. And it's because in emergency that becomes a very stressful factor for us. So I think bladder we must be able to do it by ourselves. We can have a urologist, but we can do it. Even legally also, we're allowed to do it to repair the bladder.
So
yes, bladder is a wonderful organ to heal.
And
actually,
before I just finish it, I request you please support me for this committee, for Drug and Medico-Surgical Equipment Committee. Nominations will be in May and election will be in August. Please help me.
Definitely.
Sure, thank you.
Sure, ma'am.
Thank you, ma'am.
Thank you, ma'am.
And now we can. Anything else, any pearl of wisdom anyone wants to put up before we actually end the session?
Ma'am, I have an experience about Beeline sutures. A patient was a second gravida. The first delivery was very uneventful. 5 years before, she had a 5-year child. and the second baby estimated fetal weight was less than the first baby. So I thought she will deliver very easily, and because the first delivery was very uncomplicated, I thought, okay, she will. But of course, just like any other antenatal patient, she had the regular risk. That's all, or even less risk, because I know how her uterus behaves. She delivered easily at something about 11 at night, and then started the story. Uterus never contracted at all, didn't contract. I checked the cervix, no lacerations, but she was deteriorating. Took her, packed the uterus. Those days, like, it was always back. We didn't have the backy balloon. So I just packed the uterus and took her to the theater and explained. In the meantime, started the resuscitation, sent for blood, and discussed with the attendants about the various things, and kept the blood ready and all. And we went ahead for B-line sutures. And the B-line sutures, I have finished the B-line sutures. I thought, okay, now I have compressed the uterus, I'll be fine. Very soon, I was thinking of putting the drain and coming out, and the uterus started bubbling. That said, the suture was intact, and it became so tonic, and just like a bag, it started pouting up. So the compression was not treating that atonic uterus. Then again, I counsel them before even for hysterectomy. So I just called them. I told them that the folding of uterus, the procedure of folding the uterus and stitching has failed. We are going ahead for hysterectomy. This is my experience. One of the experience of bad experience of B-link sutures. All the compression sutures. See, when we try B-link or any, we can use all the types of sutures. See, all together also. We can use B-lynch. Before B-lynch, we can close the placental bed squares, and then go for B-lynch. I mean, two types of sutures also. We can use a hybrid. Our purpose is to save the uterus,
save the mother,
and compress the beds if we have sufficient time.
Yes.
Many times the placental bed does not respond.
Retract,
so then
yes.
we have to, yes, the placental bed, we put that square sutures are the placental
What do you
bed,
think of uterine artery ligation? Does it work? Uterine artery ligation.
Definitely. It is so simple, basically. It is
Exactly.
just
So that is something that
so
everybody should know. Everybody.
Yes.
How to do that.
Yes.
Ma'am, can I have some question? Actually, I think I missed the first Abruptio placenta talks. I don't know if Madam covered this. So I actually wanted to ask Dr. Padmaja. So if it's a low risk patient with abruption who underwent abruption and a severe abruption and IUD with no preeclampsia, nothing, no other risk factors, what can we possibly do to avoid the same agony in the next pregnancy? Is there anything?
Nothing.
Okay.
Nothing. That is why she said that there is a 5 to 15% chance of recurrence.
Yes,
and
yes.
If it happens twice, then there is a 25% chance of recurrence. That is what she said.
Madam,
that recurrence is because we really can't do anything about it.
Yeah.
Yes,
it's
Dr.
very
One
difficult.
point I want to add about
to explain
abruption. Yeah. Please continue.
It's very difficult in a low risk women. I recently had a second gravida. Absolutely everything was going well. She just called me and then she had bleeding. By the time she turned up within half an hour, it was an IU. That's it. Nothing else.
Yes, absolutely. Abruption just tears off the placenta. I have one thing to add. Now we have a lot of surgical hands doing aggressive septal resections for small septa also. I feel post septal resection, the abruption rates have increased because the presentation at the point of septal resection is inadequate. Beside that, it is good. I have been seeing past 7-8 years quite frequently. We have to rethink.
That is another injury to the uterus, right? That is another injury.
Yeah, exactly.
Whether it is a myomectomy, whether it's a septal resection, whatever. It's a uterine injury.
Yes, madam.
Ma'am, do you think it is because of the septal resection itself, or is it because of
the resection went too deep?
No, ma'am.
Basal layer is
the
destroyed.
basal layer should not be involved.
Yes, exactly. Basal layer should be repaired.
Have proper placenta.
Before we end the session, I would like to have one comment from everyone who's present here. On my screen, the first person I can see is Dr. Kavitha. So we start with you, and
Yeah, ma'am, it was a wonderful and a very informative session. Most required for every practicing gynecologist today. This antepartum and postpartum hemorrhage, it is life-saving for the patient, and it is, saving us mentally, physically, and in every way. Thank you so much for this wonderful session.
Thank you. Dr. Padmaja, you are next.
Yeah. Madam, PPH is an evergreen and ever-learned topic. Evergreen, ever-learned topic. I want to add one thing. Vacuum balloon is very expensive. We are getting another balloon called Ilavi balloon. You can see on the net. Which is quite. It comes just for 4,200 or something, 4,000 and 5,000.
In Chhattisgarh, we have a Chhattisgarh balloon, which is a condom catheter. So that is not even 4,000 rupees. It's like 20 rupees that Roma was mentioning about. So,
Madam, this is it was sterilized because if we have no time,
but your condom is there and your uterus is not sterilized at that time. So, Dr. Narsavani, you are next if you want to add something. Dr. Uma, don't go away. We'll come to you.
Ma'am, it's really a wonderful session because it's every day basis for an obstetrician. It's a challenging case, either APH or PPH. Almost it's like a nightmare. That the PPH is a nightmare for every obstetrician. So the topic is so essential for every obstetrician, and very nice discussion. Thank you, ma'am, for giving this opportunity.
Yes. Thank you. Nirmala, ma'am, would you like to add something? You've been listening.
Yeah. It's an excellent topic that has been taken up because nobody can escape, no obstetrician can escape from this case. And everybody should be prepared for that and should be able to handle it and take the help from all the team, other team members and other specialties. And it's a very good topic, and thanks for all the discussion and the presentation.
Thank you, ma'am. Thank you. Dr. Niharika?
Yes, ma'am. Ma'am, I think one important thing that I would want everybody to take away is that usually we are very well prepared, but the staff keeps changing. So I think having regular drills and teaching them skills is very, very important, because we tend to forget in the flow of the job that they are the ones who are going to help us out in the dire emergency situation. And 100%. I think I learned a lot of new things. Thank you so much for this opportunity, Dr. Asha.
Thank you, Dr. Niharika. Padmavati, ma'am?
Yeah, it's very useful topic, ma'am. And one thing I want to say, each and every patient I used to discuss and counsel with the attendants. At the time of admission only, I used to send blood sample and reserve 1 unit of blood and each and every patient. Whether it is useful or not, even waste of 5 to 1,000 rupees is not a matter, but it is very useful to the patient. Immediately they will get the blood. If anything happens, within minutes they will get the blood. That is very useful for me. I am following this protocol since 20 years.
Thank you, ma'am. Dr. Uma?
Yeah, madam, it's a very useful session and you've done it very well, conducted, moderated very well, madam. And I think it's been very useful, especially some of the new things that have come up. And most important, we are with you for your next year coming elections also. And all the best for it. All the best for it.
Thank you, sir. Thank you, sir. Thank you. Dr. Annapoorna?
Yes, ma'am. Thank you again for initiating a very, very important searchlight. I hope my postgraduates are learning so much. And one thing is hypogastric artery ligation should be attempted by everybody in normal cases. Even if they don't ligate also, a dissection would help them in dire situations. It is not very hard, only we have that fear of the ureter and all. It's really not hard. Once you start step by step, and it could save a life. And saving a woman's life is saving a family altogether. So I hope everybody takes this from today's session. Thank you.
And also saving your own life.
Yes, of course, yes. Thank you, madam.
Thank you, ma'am. Thank you.
Thank you. Namaskar. Thank you. Thank you all of you for
Namaste,
being
ma'am.
here.
Sure,
I'm
all the
really
best.
sorry that we have overshot the time by 35 minutes. Thank you. Thank you for being with us for so long. Thank you,
Thank you
Mehul
also, ma'am.
and Corona Remedies for facilitating this session. Namaskar. See you again in some other webinar. Namaskar.
Thank you,
Ma'am,
ma'am.
Thank you,
please
ma'am.
share
Thank
if
you,
there is a link of the, like, if it's recorded. Do share me.
I will send the link. I will send the link.
Sure, ma'am, because I missed the first talk.
I will send the link. She had beautiful slides.
That is exactly why I'm
slides
asking.
were very good.
Yeah, beautiful
I had
slides.
OP at that time, so I couldn't. Yes, ma'am. Thank you.
Thank you.
Bye, ma'am.
Bye, ma'am.
Bye,
Bye.
bye, everybody.
Bye.
Bye, ma'am.